We are in live.
Okay. Murli, do get connected. Yeah. Very good evening to one and all of you. It's evening for us in this part of the country, and a very warm welcome. And I'm so sure that all of us who are going to watch this webinar are going to learn a whole lot with absolute top-notch speakers here. So a very warm welcome to you, Dr. Gordon. It was so nice that you've been agreed to be a part of this very interesting webinar. And I'm sure he needs no introduction at all. He's been a senior consultant neurologist at the National Hospital, Queen Square, Moorfields, St. Thomas Hospital. And now, although he's retired from clinical practice, he remains active in teaching and research. He was the editor of the Neuro Ophthalmology for 10 years and was the founder and the first president of the UK Neuro Ophthalmology Society. And we are truly lucky to have him with us. We have with us again another very prolific ophthalmologist, neuro-ophthalmologist of the globe, Dr. Clementine, who's again a senior consultant neuro-ophthalmology and also the director of the Graduate Medical School of, and besides that, he is the group chief of the National University Health Service Cluster and director of the Division of Graduate Medical Studies at the National University of Singapore. Dr. Rashmin Gandhi, I think, is stuck at the airport, but he has sent his recorded talk, and I think he would stay connected. He's a senior consultant neuro-ophthalmologist and also a cataract and refractive surgeon and associated with the Center for Sight at Hyderabad. We are very lucky to have Dr. Shikha Basi, and I owe so much to Dr. Pradeep Sharma and Dr. Shikha, who did so much for me during my ARC days and made my neuro-ophthalmology meetings mind-blowing and so informative. She's the Deputy Director of the Department of Neuro-Ophthalmology at Shankar Nethralaya, Chennai, and another amazing figure. And when she talks, it'll be so crisp and informative that it'll be like 2 + 2 is 4 and exactly 4 and nothing less and nothing more. A very impressive speaker. And I'm lucky, as always, to have Dr. Murli there. He's not just a senior consultant in glaucoma, neuro-ophthalmopediatric. He's actually a backbone for our Eye Foundation and has one of the maximum OPD patients possible. And the way he deals with everything is the most interesting person to have amongst us. And so without wasting time, we shall go on to our first speaker, Dr. K.G. Srinivasan.
Madam, Dr. KGS has joined, madam. KGS has joined, madam.
Huh?
He's joined.
Yeah, he's joined, madam.
Yeah, we'll go on to our first speaker, and that's going to be Dr. K.G. Srinivasan, who is the director radiologist from KG Scan Center, Madurai. And I've heard so much about him from Dr. Murli, and I know in the next 15 minutes, he's going to keep us just totally enthralled in his talk, neuroradiology with reference to neuro-ophthalmology. On to you, Dr. Srinivasan.
Yes, please. Yes, sir. Yes. Can you hear me?
Yeah, we can. Yeah.
Yeah.
Should you go to slideshow?
Yes, slideshow. I think you are seeing my slideshow. Am I correct?
Yeah, now fine. It's totally fine.
Yeah. Yes. Thank you very much to give me this opportunity. Straight away, we will go to subject, orbit and optic pathway. The anatomy. Orbit is made up of bony structure. It is a cone-shaped bony structure with apex facing posteriorly and base anteriorly. And important bones, it is a frontal process of maxilla, lacrimal bone, lamina papyracea, and lesser wing of sphenoid along the medial aspect, greater wing of sphenoid, and zygoma along the lateral aspect. And inferiorly, it is formed by maxillary. Antra-superiorly, it is formed by, it is a roof of, it is a frontal sinus. And coming to orbital apex, where we are seeing classically, this is antroclinoid process, superior optic strut and inferior optic strut, lateral wall of sphenoid sinus. And this is main important foramen. This is called optic foramen, and you can see the optic canal that is, and this is a supraorbital fissure, infraorbital fissure, anything go into the infratemporal fossa and pterygopalatine fossa. And the blood fractures are quite common in floor as well as medial wall. And regarding the anatomy of muscles, there are 7 muscles. You can see the 4 recti, medial, inferior, lateral, and superior rectus along with levator palpebrae superioris. And anteriorly, we can see the horizontally placed inferior oblique. And you can see the superior oblique muscle over here. You can see the superior oblique muscle. And one important structure, what we are seeing is the superior ophthalmic vein, which is situated between optic nerve and SRLPS complex. So where we have to look, and it is a very important band, so-called SRLR band, connecting the LR muscle and SRLPS. You can see the SRLR band. This band is very important whenever we are suspecting heavy eye syndromes or high myopic eye. We have to carefully think that particular band. And this T2FS corneal sequence is important sequence to identify the optic nerve pathology, which will look like normal target appearance, and the central low signal area is optic nerve, and the surrounding bright signal area what we are seeing is subarachnoid spaces. Normally, the optic nerve should be seen as a classical target appearance. And this is full pathway. What you are seeing is the full course. You can see the intraocular and intraorbital, intracranial, intracranial segment of optic nerve, and optic chiasm is formed over here, and the decussation is taken over, and you can see the optic tract, and you can see the classical LGB and the optic radiation, how it is coming, and this calcarine cortex. This is regarding normal anatomy of optic pathway. Coming to cases, this patient presented with vision loss, left side optic neuritis, with a strong suspicion to rule out multiple sclerosis. So we have to work out brain as well as spine and orbit. This is multiple sclerosis protocol. Whenever you are suspecting MS or MOGAD or NMO, the protocol should include optic pathway. It should include from the orbit, it should include the pericallosal areas, brainstem, subcortical regions, and the entire spinal cord, including conus, we have to include. And this patient suspected left optic neuritis. This is a normal appearance where we can see the target, and here the target is totally gone. That means retrobulbar neuritis. Brain, there are multiple lesions, and you can see the periventricular lesions very classically seen, and you can see the large periventricular demyelinating plug. After giving contrast, the broken ring, this broken ring, one side enhancing, that is the opened up rim. This is very, very classically seen with demyelination, especially multiple sclerosis. And what is this multiple sclerosis? This is nothing but immune-mediated disease and disseminated over time in space, typically located in periventricular, subcortical, cerebral white matter, brainstem, corpus callosum, pericallosal region. CSF classically seen as monoclonal bands. And in the spinal cord, you can see the involvement is confined to single segments only, 1 or 2 segments. And the cord, you can able to appreciate classical location and at posterior column or lateral column involvement. This is very classically seen. And the brain lesions, you can see the corpus callosal involvement, so-called dot and dash sign. You can see the corpus callosal involvement, and pericallosal lesions are typically seen, and it is very classically seen with the and the periventricular Dawson's fingers appearance will be seen. You can see the multiple ovoid-shaped periventricular lesions, classical Dawson's fingers appearance in sagittal slices. The second case, 18 years old female presenting with vomiting, visual loss, and quadriparesis, and continuous vomiting. Continuous vomiting means carefully we have to look for area postima. You can see the area postima involvement, and the spinal cord involvement is more than 3 segments. You can see the more than 3 or 4 segments are involved over here, and you can see the classical perichiasmic portion of the optic pathway. You can see the perichiasmic portion of optic pathway involved, sparing of corpus callosum and brainstem lesions are there. This will be commonly seen with neuromyelitis optica. Why neuromyelitis optica involving area postima and periventricular region. The reason is it is the IgG autoantibodies of NMO is directed against aquaporin water channels. They are predominantly concentrated more around ventricles. That's why we are having commonly this neuromelodic optical lesions in area postima as well as periventricular locations. This is third case, 40 years old female presenting with left side vision loss and paraparesis. Here what we are seeing is the lesion involving the conus medullaris and the lower thoracic cord. And you can see the central portion of the spinal cord is showing bright signals. And in optic pathway, it is perioptic neuritis. Apart from optic nerve involvement, the nerve sheath inflammation is very classically seen. These findings are commonly seen with MOGAD, myelin oligodendrocyte glycoprotein associated antibody disease. So, how to differentiate these diseases? By seeing the optic nerve alone. If you are carefully seeing, you can able to nicely appreciate in multiple sclerosis, the nerve is involved and this is retrobulbar segment. In neuromyelitis optica, it is a perichiasmic segment of optic nerve is more affected. In MOGAD, apart from nerve involvement and perioptic neuritis is another important feature. And though these things are very classical, we can differentiate by seeing where the lesion, is it nerve or perioptic subarachnoid space is inflamed, or we can see the perichiasmic segment of optic nerve. Then by seeing the spinal cord and area postima, if we are suspecting NMO and this is, we can see the area postima involvement is there, and a long segment cord, it will involve more than 3 or 4 segments of the spinal cord will be involved in NMO. And MOGAD, if we are saying this is commonly seen in lower thoracic cord and the conus medullaris, this is one important feature, and it will involve also more than 2 segments, but corpus callosum involvement is not there. And if you are taking MS and the involvement is only 1 segment involvement, and you can able to appreciate the portion involvement is a posterior column and lateral column involvement. So this is the things classically we can see with MS, and we can differentiate these 3 diseases by screening the brain as well as the spine. And this young female presented with internuclear ophthalmoplegia. So whenever internuclear ophthalmoplegia patient is coming, they will ask where is the lesion. It is medial longitudinal fasciculus. This patient presented with the right side vision loss with MLF features. So we have to carefully look into the nerve. You can see the normal target sign on left side, and you can see the absence of target sign. That means it is retrobulbar neuritis. And here, this is the classical location. What you are seeing is the bright signal lesion in the location of MLF. MLF is situated lateral to abducent nucleus. This is normal abducent nucleus, and this is the site where we have to look. And this is the 7th nerve motor nucleus wind around the 6th nerve and form the facial colliculus. It will go like this. 6th nerve will traverse anteriorly, and you can see how it is traversing. And this is the location where we have to look for MLF. And here demyelination in the MLF and brain screening classically demonstrating multiple periventricular Dawson's fingers over here. And you can see the post-contrast broken ring appearance, and you can see the optic neuritis. So it's a case of MS presenting as internuclear ophthalmoplegia, and the lesion at left side MLF and right side retrobulbar neuritis and brain lesions. So the lesson, we have to carefully look all these structures, and we have to carefully work out trigeminal neuralgia, MLF lesions, all these things we clearly rule out to multiple sclerosis, especially in young females. This is adult presented with bilateral INO, internuclear ophthalmoplegia, and you can see the diffusion restricting areas in both sides MLF classical location. One side very large, another one is very small, and we can see the dissection of the left vertebral artery. You can see the intimal membrane. So it is ischemic cause, dissection producing thrombus and pons producing bilateral INO, and this is very classical MLF location. The cause is dissection of the vertebral artery. And this patient presented with the sudden loss of vision left eye. And here the target sign is absent over here. That means something wrong. Is it neuritis or something else? And we have to carefully, but because they are suspecting ischemic etiology. No problem, madam. Pardon?
Yes, you
No
may
problem, sir.
doctor.
Continue, sir. Continue.
And this is ischemic optic neuropathy they were suspecting, and we have worked out with neck angio, non-contrast, time of flight technique. What you are seeing is the normal vertebral arteries. This is left vertebral artery. This is the right vertebral artery. The time of flight technique, this is non-contrast. We can see the vessels without using any contrast. And this is anterior circulation workup. And we can see the normal CCA, normal ICA on right side. This is normal vertebral artery. When we are going towards left side, we can see the CCA is there, external carotid vessels are there, and internal carotid, which is not at all seen, completely occluded. This is a normal left vertebral artery. That means something wrong with the ICA. And going to the raw data, and you can beautifully appreciate this is the normal vessels on right side, and you can see the completely occluded left ICA. And seeing the raw data, there is an intimal flap, that is ICA dissection producing occlusion of the ICA, and there is a ophthalmic artery is occluded. It is ischemic optic neuropathy responsible for sudden loss of vision on left side in young male 34 years. And this is one which we always have to do either carotid Doppler or neck angio as well as brain angio, and we can give the perfect diagnosis what is the reason for sudden vision loss on one side. And this young patient presented with the post-traumatic optic neuropathy on left side. Whenever you are suspecting post-traumatic optic neuropathy, you should take CT as well as MR, provided there should be no foreign body. And CT to identify the fractures. CT, we can see the fractures nicely. MR, we can see the nerve, which I have told how to identify. You can, this is anterior clinoid process, and this is the superior optic strut, and this is inferior optic strut. This is the lateral wall of sphenoid sinus. We can see the fracture over here. Nicely, we can identify the fracture. And the nerve, we can see the typical location where we can appreciate nicely the optic nerve contusion within the intracranial segment responsible for post-traumatic optic neuropathy. So whenever we are suspecting post-traumatic optic neuropathy, we should use both CT as well as MR to identify and locate the lesion. This patient presented with primary optic atrophy on both sides, and this is the fundus picture. And this is the lateral scanogram. If you are carefully seeing, nothing you can identify in this. This is the normal anatomy. This is the skull base, anterior skull base, and this is the planum sphenoidal, anterior clinoid process, anterior wall of cella, floor of cella, posterior wall of cella. This is posterior clinoid process, and this is the clivus. And we are not able to see anything, basically speaking, but by doing CT, this is any CT without using contrast, something there in the anterior aspect of skull base. After giving contrast, we can see the beautiful enhancing, brilliantly enhancing lesion in the suprasellar location. And this is the cella. We can see the cella is absolutely normal. This is situated in the suprasellar location. And the sagittal images nicely demonstrating which is situated in the suprasellar planum sphenoidal area. There is a brilliantly enhancing lesion, and a few important signs to differentiate here. The pituitary fossa is looking absolutely normal. There is pneumosinus dilatans where the sinus is hyperpneumatized, and this is a hyperostosis of the skull base planum sphenoidal. That means it is having rich vascularity, and there is a dural tail sign, and this is signs commonly seen with the meningioma. So it is a suprasellar planum sphenoidal meningioma with the compression of optic chiasm responsible for bilateral primary optic atrophy. This is typical classical case of meningioma. Another patient presenting with the field defect of bitemporal hemianopia with bilateral primary optic atrophy, and this is the fundus picture, and this is the scanogram. In this case, if you are carefully seeing few important things, there is rarefication and demineralization, and there is double flooring. You can see the double flooring, one floor over here, one floor over here, and the expansion of the pituitary fossa and rarefication of the posterior clinoid process and clivus. These are the typical locations. And there is a mass in cellar suprasellar. The mass is originating from cella going above, and the classical figure of 8 configuration has come. And you can see the MR beautifully demonstrating the pituitary macroadenoma with the compression of optic chiasm responsible for primary optic atrophy. So it is a case of primary optic pituitary macroadenoma, compression of optic chiasm, and primary optic atrophy. And I have given comparison how to see both pictures. Here the pituitary fossa is absolutely normal in meningioma, and you can see the expansile pituitary fossa in pituitary macroadenoma, and double flooring will be there. And you can nicely see the mass in the suprasellar location. And you can see the mass is coming from cella, extending into the suprasellar. The expansion of the cella, thinning of the floor will be there. Here, the pituitary fossa will be absolutely normal. Only the lesion is just above. And other findings are, you can see the hyperostosis, and you can see the pneumosinus dilatans, which is not seen over here. You can see only thinned out planum spinatum will be there. And this is MR picture beautifully demonstrating everything. And you can see the dural tail sign. And this is another picture of meningioma, pituitary macroadenoma, where the lesion will come from cella, go to the suprasellar location. Sometimes you can get the apoplexy. Whenever there is pituitary macroadenoma with apoplexy, we will have sudden onset nerve palsy, sudden onset of severe headache will be there. And this is one among the case, pituitary macroadenoma with apoplexy with Turner palsy on right side. And we can see the mass extending into the right cavernous sinus location, where third to sixth cranial nerves are situated. And this is one among the case, apoplexy presentation is sudden onset Turner palsy with headache. And a child presenting with optic atrophy, this is classical location of suprasellar optico-chiasmic glioma with a very high Poline peak in spectroscopy and reduction of rest of metabolites commonly seen with gliomas of suprasellar nature. It is a optico-chiasmic hypothalamic glioma presenting as optic atrophy in a child. Elderly female, right side Turner palsy, pupil involvement, coexisting with fourth to sixth cranial nerve, with a strong suspicion of to rule out any aneurysm in circle of Willis. And this is the clinical picture, restriction of all movements and a Turner palsy. And we can see there is a large cavernous ICA aneurysm with partial thrombosis and various layering we can able to appreciate. Central lumen, patent lumen we can able to see. And we can see the compression of this classical location where third to sixth cranial nerves are compressed. And you know, pupil involvement means it is a compressive lesions coming from outside can compress over the pupillary fibers very early. That's why we are having aneurysm or any mass lesion producing pupil involving Turner palsy. And this young patient, diabetic patient with ketoacidosis nature, more than 400 and more than 11 is the A1C, and presenting with the sudden vision loss on both sides. Bilateral Turner palsy, right side hemiparesis with very severe headache for 15 days duration. And this is the MR diffusion weighted imaging. Diffusion weighted images are very, very important to look for any ischemic optic neuropathy. You can see the nerve is bright, and that means it is severe ischemic optic neuropathy. You can see the infarcts in the brain parenchyma, and there is some diffusion restricting lesions in the sphenoid sinus have come, and you can see the infarct in the MCA territory. And this very important conventional image, there is a large mixed signal lesion in the sphenoid sinus with low signals, and you can see the vessel of left ICA is inflamed. You can see the vessel wall is significantly inflamed. The lesion gone to the cavernous sinus and engulfing the second to sixth cranial nerves. That means it is a fungal infection, invasive mucormycosis of the sphenoid sinus gone to the cavernous sinus and engulfing the ICA, producing vasculitis with the ischemic optic neuropathy. Apart from that, you can see the vessel is so much pruned out over here, vasculitis and vasculitis induced infarcts. So it is invasive fungal sinusitis with the cavernous sinus extension and ischemic optic neuropathy. This lady, 60 years old lady, presented with the left side sixth nerve palsy. You can see the clinical picture. So this is the location where the sixth nerve will come. You know, it is a Dorillo's canal and it will go like this. So we have to identify the cause. Where is the destructive lesion? You can, this patient, after screening, you can see the destroyed area and the clivus where the Dorillo's canal is situated. We have screened out the lung parenchyma. It is a bronchogenic carcinoma where producing secondary deposit in the clivus, engulfing the Dorillo's canal and sixth nerve, producing a sixth nerve palsy. And this is the one how we have to work. We have to screen for rest of the regions to localize the primary, and this bronchogenic carcinoma with clival secondaries. Last few slides were how to work out the raised IC. Can I stop? Can I stop? Can I stop or proceed?
Hello. Hello.
No, sir, you can continue, sir.
Yeah, please. It is a raised ICT, how to work up. It is unexplained headache presenting as papilledema, projectile vomiting, raised blood pressure, and bradycardia. These are the causes we have to work out: CVT, tumor, hemorrhage, infection, head injury, hydrocephalus, cerebral edema, status epilepticus. How to look for papillary edema in MR? This is a normal optic nerve. We can see the sheath over here, and we can see the nerve, and the small spaces of perioptic space will be there, and usual thickness will be almost equal to the medial rectus muscle. This is normal. Whenever there is papillary edema, you can see the tortuous course, number one, vertical as well as horizontal tortuosity of the nerve, and you can see the gross widening of the perioptic subarachnoid spaces, and reverse cupping. You can see the reverse cupping of the optic nerve head, where the prelaminar zone will project inside, and you can see the Gasserian ganglion. You can see the Gasserian cistern, and the cistern as well as Meckel's cave will be grossly opened up. And carefully we have to look for the sinuses, whether it is thrombus there or not, transverse sinus is occluded or not, all these things. And carefully we have to look all these structures. And you can see the prelaminar zone almost projecting inside, and you can see the widening of the perioptic subarachnoid space, and you can see the empty cell loss syndrome. All these things we have to carefully look. And this is another case, beautifully how it is seen, and there is a thrombus in superior sagittal sinus. Normally, the thrombus cannot be seen in CT. If it is hyperdense, means it is thrombosed, and you can see there is a cross thrombus in the superior sagittal sinus, and the cortical veins are also thrombosed, and this is the infarct, venous infarcts. Venous infarcts are invariably hemorrhagic nature, and they will not obey the arterial territory. That's why we have to carefully look all these things. And MR, and here contrast, if we are giving contrast in CT, some of the important signs, so-called empty delta sign, you can see normally this delta will be opacified normally. If it is thrombosed only, we can able to see the intraluminal filling defect. This is called empty delta sign. And another sign is called the tramline sign. You can see this thrombus within the superior sagittal sinus. We can see the thrombus within it. And these are the things which carefully we have to look when we are dealing with the contrast CT, CT of the brain. And MR venogram, we can do without contrast. Nicely, we can able to, this is a normal superior sagittal sinus. Whenever there is a thrombosis, there is complete occlusion of we can see the thrombus completely occluding, and there is absence of signals in superior sagittal sinus and transverse sinus. So very, very important, we have to do contrast study. Whenever we are suspecting thrombus or whenever we are suspecting stenosis, to differentiate these two both conditions. If we are not seeing any thrombus, we have to differentiate whether it is stenosis or hypoplasia responsible for the flow compensation. We have to do contrast study. This is one among the case presented as papillary edema. MR venogram was negative, except there is small narrowing of the left transverse sinus. So they were asking, is it stenosis or is it any previous thrombus producing narrowing of the pathways? For that purpose, we have worked out. You can see the superior sagittal sinus, there is a chronic thrombus, and there is a dural AV fistula has formed, and you can see the extensive collaterals coming from external circulation. And if we are doing contrast study, we can see the narrowing of the segment. You can see the narrowing of the transverse sinus. So to identify the stenotic area, we have to do post-contrast study. Otherwise, we cannot differentiate, is it stenosis or is it thrombus producing these occlusions. And the child with the pale disc, this is typical appearance of periventricular leukomalacia. You can able to appreciate thinning of corpus callosum with the dilatation and swelling of lateral ventricles and periventricular bright signals. If we are drawing a line, this is the normal white matter. You can see the normal white matter and any abnormal white matter, which will be seen classically like this. This is a typical case of periventricular leukomalacia. It is end-stage PVL. This patient presented with visual hallucinations, visual type of seizures, and hemianopia is there. There is a typical case of calcarine cortex, colloidal vesicular stage of cysticercosis. There is a ring enhancement, and you can see the dying stage, and there is a perilesional edema, and the scolex is seen beautifully inside it, and the marginal scolex is seen. This is typical case of colloidal vesicular stage of cysticercosis in calcarine cortex, present as field defect and homonymous hemianopia. This patient, sudden onset homonymous hemianopia on right side, it is a diffusion weighted sequence demonstrating acute infarct in right calcarine cortex. And this is diffusion restriction, and this is low ADC and the flare positive angio. There is a complete occlusion of PCA. PCA normally it will be like this. It is totally completely occluded. This is normal PCA on opposite side. Another patient presented with the cortical blindness. We can see the bilateral PCA occlusion with the bilateral occipital lobe infarcts are there. And this patient occipital blindness because of osteosarcoma with calcarine cortex metastatic deposits. Presentation is a slow onset cortical blindness. Here the culprit is metastatic deposit. And you can see the extensive secondaries in the lung parenchyma as well as Clival also. And myasthenia patient, whenever we are suspecting myasthenia gravis, mediastinal evaluation is a must one. And this patient, you can see before and after neostigments test and evaluating for the mediastinum. There is a thymoma. You can see the thymoma in the anterior mediastinum. This is MR picture and this is the CT picture. So whenever myasthenia we are suspecting, we have to do anterior mediastinal workup, and where the thymoma is situated, typical location, we have to identify it. Coming to Horner syndrome, we have to locate and evaluate oculosympathetic pathway. Oculosympathetic pathway starting in the hypothalamus, the first order going to the spinal cord up to C8D1 level. C8D1 level where the stellate ganglion is situated. From there through the brachial plexus, it will go to the superior cervical sympathetic ganglion. It is situated at carotid bifurcation. Up to here, that is up to here first order, up to here that is second order. Then the postganglionic starting along the adventitia of the ICA, going to the cavernous sinus, and fifth and sixth cranial nerves, it will supply the molar as well as iris. So this way we are having ptosis, meiosis, anhidrosis, loss of ciliospinal reflex, and anaphthema. These are the things. So it is essential or preganglionic or postganglionic we have to work. This is a typical case of bilateral thalamic as well as midbrain infarct presenting as the central type of Horner syndrome. And this is the lateral medullary syndrome presenting with the central type of Horner syndrome. And there is a shrinks in the cervical cord. You can see the shrinks in the cervical cord with Arnold-Chiari malformation. This is presentation is Horner syndrome in this case. So these are the one preganglionic. And you can see a child presenting with, you can see the ptosis. You can see the ptosis over here. Compare on this side, you can see the people over here. And you can see the meiosis, ptosis, meiosis, and anhidrosis also. This side totally anhidrotic. One on right side, this is anhidrotic brain, anhidrotic face on this side. So right side ptosis, meiosis, anhidrosis, Horner syndrome, and this is ulnar Clahand with the. And if we are evaluating for the brachial plexus, there is brachial plexus avulsion injury during childhood responsible for Horner syndrome in this baby. And adult patient presenting with Horner syndrome right side, you can see the meiosis, you can see the ptosis and anhidrosis on this side going for mediastinum, and you can see the Pancoast tumor with infiltration of stellate ganglion responsible for Horner syndrome. So carefully we have to look for Pancoast syndrome also. Other patient presented with the sudden onset neck pain with the Horner syndrome, there is ICA dissection. You can see the intimal membrane with ICA dissection, and this is the normal ICA presenting with the postganglionic type of typical case of Horner syndrome. And intracranial course of, you can see the cavernous sinus location, metastatic deposit in breast malignancy presenting as Horner syndrome. So these are the areas carefully we have to look. And last one slide, progressive supranuclear palsy. Always whenever we are suspecting progressive supranuclear palsy, we have to carefully look for midbrain evaluation and volume of the midbrain along with the pons. The midbrain will be significantly reduced in size because this tau protein is deposited in the superior colliculus substantia nigra and in the tegmentum. And this is the one carefully we got. So it is called as penguin sign since midbrain is affected. And this is the normal posterior surface of midbrain where the convexity will be there. In whenever we are suspecting progressive supranuclear palsy, where we can see the loss of this normal convexity, the classical Mickey Mouse sign will be there. So these are the things carefully. Whenever you are suspecting PSP, carefully look for midbrain atrophy, periaqueductal gray matter atrophy, and where the tau protein is situated. And we can see the smudging of pars compact of substantia nigra. And this classical appearance of morning lily sign will be seen whenever we are seeing this. Thank you very much. Thank you very much.
Thank you. Thank you, Dr. Srinivasan. What an amazing talk it was. Like, I think we would like to rewind it and watch it again and again to learn so much more. I'm sure every single person in this amongst the speakers would agree that it was a truly interesting talk we heard. Thank you so much for the effort you have put in for us. So, Murli, would you like to take the first question?
Sir, you had presented a number of cases of raised ICT, and sometimes how do we find out if a shunt, VP shunt that has been placed, is it working or not? How do we make out?
Especially whenever
Could you stop sharing your screen?
Yeah. 1 minute. Yeah.
Yeah.
Can you see, whenever we are putting VP shunt, that particular ventricle will be collapsed immediately, number one. Number two, we will lost that periventricular interstitial edema. That means the shunt is functioning. If there is no reduction in size of that particular side ventricle, and if there is still presence of periventricular interstitial edema, and it is suggestive of the shunt is not functioning. That is what two important things we have to. One is ventricle size, other one is periventricular interstitial edema. In CT, it will be seen as hypotensity. In MR, we can able to appreciate bright signals in periventricular white matter.
Dr. Gordon, you want to talk? You ask anything?
Oh, yes, I just wanted to say what a wonderful journey that was through the anatomy. Fabulous illustrations and so much covered. I'm glad it was recorded so that people can go back to it. If I may make just one or two comments on posterior ischemic optic neuropathy, it's an important topic. I have told trainees if they never make the diagnosis in their life, they might be wrong once, because it's more often a compressive problem or something else. But the two situations where we do see it are giant cell arteritis, that's a very important cause, but also perioperative optic neuropathy, particularly with spinal surgery and so on. And we showed some time ago that as you showed, that you can make this diagnosis with DWI immediately. And although there's nothing to be done, this is very helpful for the surgeon and the patient because you can give them a diagnosis. A point about pituitary apoplexy, unfortunately, MRI has resulted in overdiagnosis of this because, of course, all tumors, particularly fast-growing tumors, are susceptible to regions of infarction and hemorrhage. And so you very commonly see in pituitary adenomas a small hemorrhage within the tumor. And this is now being diagnosed as pituitary apoplexy, and they're going through the procedure for that. It's quite unnecessary. And it's only necessary to manage as pituitary apoplexy with the risk of pituitary failure and so on, which is so urgent, if there is evidence of hemorrhage outside the pituitary gland. So I think that's been a problem. With the venograms, I absolutely agree that contrast venography is essential with a lot of the differential diagnosis, but CTV does have some advantages. One is that you can see the anatomy of the skull base, and this can give a clue to an aplastic transverse sinus, which is something that on contrast studies is often mistaken for a thrombosis. But the anatomy of the skull base will confirm an aplastic transverse sinus. So there was a really fantastic talk. I enjoyed it. Thank you.
Dr. Pradeep, you would have anything to ask?
I think nothing specific. Yeah, it's been a comprehensive talk. It's a wonderful talk. So there are so many things.
Yeah. Yeah. Dr. Clement, any questions for him?
None in particular. Agreed that that was a tour de force of neuroanatomy. We will all be revising that, I'm sure.
Yeah. When you talk about the imaging systems, would you say that the 3T imaging system gives more detail to 1.5T imaging systems?
Madam, especially 3T will score over whenever we are going for very small lesions, like very small demyelination, like MLF evaluation or some nucleus evaluation, and especially nerve 3D sequence, 3D CIS, there is 3D CIS or SPACE or FISTA, whatever the company we are using. If you are suspecting, suppose one hemifacial spasm is there or trigeminal neuralgia is there, we have to look for a nerve less than 1 millimeter. The details of a seventh nerve. Seventh nerve means we should look for a nerve root, exit zone, cysternal segments, intracranial segment, labyrinthine, how it is going for. Same thing, the working and the vessel diameter also less than 1 millimeter. So is it ICA producing or is it any vessel producing compressive element? Same thing considered with the trigeminal neuralgia. Apart from that, especially third nerve palsy, we are strongly suspecting aneurysms, the small picking up that aneurysm or any compressive elements or thickening and edema of the nerve as we are suspecting any mononeuritis, all these things. 3T will definitely score over. And post-contrast evaluation also, the resolution going for less than 1 millimeter sequences are available, 3D sequences. And especially MR, angio, MR, we know without contrast also in 3D, the resolution is extremely good. And we can see the nerve. Suppose if we are suspecting skull-based tumor, 9th thoracic neurology, we can see the glossopharyngeal nerve, we can see the 10th nerve, and we can see the carotid space where how the 9th, 10th, 11th encircling it, all these things, and cavernous sinus evaluation, 3, 4, 6, beautiful coronal sections in post-contrast. Everything we can see, there is no need for guess in 3T. 1.5T definitely, we are on little bit lower side only. But there is no need that we will miss it. Fine-tuning will be better with especially demyelination, small lesions.
Well,
SNR will be
one thing with demyelination that this resolution can show is that every one of those lesions is centered on a venule. And this is something we've known from the pathology for some time. But it's very clearly how these antibodies are getting into the parenchyma is through venules, and we've known for even longer that this happens in the retina. But because there's no myelin here, we don't get demyelination. But there are changes in the retina in MS, but the leakage of venules has been known for decades to occur in patients with multiple sclerosis if you look for it. So that's these very high resolution MRs have really tied together the neuropathology of MS. It hasn't got us any further.
It's especially 5T and 70s are available, started coming, and where we can see the perivenular, that Sargas beautifully told, this classical corpus callosal, pericallosal region, perivenular lesions, and especially fifth nerve nucleus, where it is, you can say confidently, yes, this is the juxtacortical lesions, and spinal cord, where it is the central column or it is lateral column or posterior column is affected. And fine-tuning with confident diagnosis, we can give it with 5T, 70. Now it's available. I don't think so another 10 years, most of the countries may be 5T or 70.
No, but the other condition where I think this is also the case is Behçet. We know from the retina again, but in the brain too, the lesions are centered on venules.
Thank you very much, Dr. Srinivasan. Thanks a lot. We would look forward to hearing a lot from you in the future too. We go on to our next speaker, Dr. Gordon, who's going to be talking to us on unraveling paroxysmal diplopia. And on to you, sir.
Thank you, madam.
Okay, here we go. Share screen. Am I sharing my screen?
Yes.
Yes, sir.
Excellent. Okay. So we just need to start. So this is a talk on paroxysmal diplopia. And I don't think the videos are not actually very helpful. So we won't be showing the videos. I don't think they'll show very well. And these are all cases. You can see the slides okay? Can you see the slides?
Yes.
So here's the first case, 68-year-old man, 1 year history of intermittent horizontal diplopia. It appeared to be occurred any time as far as he was concerned, but never lasted for more than a minute. It was, however, especially likely to occur when he's reversing his car, Also, his family complained that from time to time, his eye looked what they call starey, wide-eyed. And the referring neurologist said that his eyes kept changing while he was examining the patient. And sometimes he looked as though he had a third nerve palsy, but sometimes it looked more like a lateral rectus paresis. So here you can see the findings. So this is just an examination, 9 positions at rest, and there's not much to see wrong here. But what we've done here, first of all, we've asked him to look up for a period of time and then look down again. So here he is at rest again. You can see my pointer?
Yes, yes.
Yeah, here he is at rest, and here he is looking down normally. Now we've asked him to look up for a period of time, a matter of a couple of minutes. And here now looking straight ahead, you can see that he has lid retraction here. And that this is maintained in down gaze. Now, the other thing that we've asked him to do is to look over to the right for a period of time, and this all looks fine. Now we've asked him to look to the left for a period of time, and now when he looks back to the right, you can see that there is impaired abduction of the right eye, which improves after time. So you can see why the referring neurologist thought this patient might have a lateral rectus paresis at times. But in fact, this impaired abduction of the eye is due to spasm of the medial rectus following sustained gaze to the left. Now on attempted abduction, there is spasm of the medial rectus, which lasts for many seconds. And there's a similar thing happening here with the levator muscle. And in fact, there was some evidence of a mild ocular motor paresis on the right at rest, a little bit of ptosis here and so on, but not much. And no, I'm all right, thanks.
You don't want it?
No, I'm just talking to someone. Thank you. So we're not going to show the video. And this patient had an aneurysm, which is just affecting the third nerve as it enters into the cavernous sinus. So this is a case of ocular neuromyotonia, and he was cured with carbamazepine. So neuromyotonia had been known about for some time in peripheral nerve, and it was originally described as a spasm that was abolished by curare. So it looked like myotonia, but it was abolished by curare, so clearly it was arriving in the nerve. So unfortunately, they decided to call it neuromyotonia, whereas they would have done better to call it neurotonia, because it's nothing to do with myotonia at all. This is relieved by carbamazepine. What was unusual about this case was the fact that it was a compressive lesion affecting the nerve involved. And yes, so we did write it up. But it's actually much more commonly seen after radiotherapy. And this is how it was originally described in limb muscles. particularly following radiotherapy to the involving the brachial plexus. Now, this is a much more typical case. This is a case that I saw when I was spent some time with Bill Hoyt in San Francisco. And this was a little boy who had radiotherapy. And here he is looking to the right, no problem. Here he is, sustained gaze to the left, looks normal. But now when he looks back to the right, he's got impaired adduction of the left eye. So here, the lateral rectus muscle is in spasm. And this is the neuromyasthenia that I've seen most commonly has been involving the sixth nerve following radiotherapy. And again, this can be cured with carbamazepine. And this is Bill Hoyt's hand. He had unusually long fingers. So the point I'm trying to make from all of this is that if a patient has paroxysmal diplopia, try and find out if there's anything that brings it on. And if there is, and it's possible to do so, then try it out. I mean, the clue with the first man was that he used to get this when he was reversing his car. Of course, in the UK, we look over our left shoulder so that you could work out what was going on from that. So this is a younger man, 30 years old. In fact, he was working in Hong Kong, and I saw him over a few years after this first consultation. And he complained of a 6-week history of intermittent vertical diplopia, no precipitating factors, so nothing we could identify that might bring this on. Never lasted longer than 10 seconds, but was very, very frequent, every 10 to 15 minutes during the day. No significant past history. So this was this was the pre-digital era. So we sat him in front of a camera and just kept doing positions of gaze over and over and over again. And we got through 5 rolls of film. And these are just the relevant photographs. And these show how he is when not having an attack with a pretty normal ocular movements. But then during an attack, what we find is that rather like the other chap, he's got this spasm of the levator and also the superior rectus on the right. So, and this was the cause of the double vision. So he had impaired down gaze and some spasm of the levator muscle on looking down and to the right. So it seemed to be in third nerve territory again, but only involving the superior division. And he had multiple sclerosis. There was a possible lesion, there was a possible lesion in the midbrain, but more definite were the fact that he had all of these white matter lesions, periventricular and so on, typical of MS. He'd had no previous episodes. And again, he was completely cured by carbamazepine. And what I did with him, on the assumption that this was would resolve eventually, every few months he came off the carbamazepine, and clearly remyelination had occurred. And after a couple of years, he found that the attacks didn't didn't recur when he stopped the carbamazepine. But he did go on to have further MS relapses over time. So this is a brainstem paroxysmal event as a clinically isolated syndrome in MS. There are many, many other paroxysmal events in MS. One of the commonest is so-called tonic spasms. And this is where when a patient starts to move, they get a spasm of usually an upper limb or lower limb. And these, we believe, are related to demyelination, but neurons that are otherwise intact that are vulnerable to this kind of paroxysmal activity. And again, they tend to respond very well to carbamazepine. So this is a woman actually from Wales. Oh, no, sorry, this isn't the woman from Wales. That's the next one. So this is a patient who started to get double vision when bending forwards, but she'd had this since childhood, but it had become a particular problem because she'd started to wear some very high knee-length lace-up boots. So she was spending a long time bending forwards, lacing up these boots. And when she stood up, she would see double transiently, just for a few seconds. And observers would say that her eye seemed to be bulging. So the video doesn't show us very much, but she had perfectly normal eye movements, but she had a pulsation of the right eye. It was pulsating, and she had a combination of orbital varices. So this was accounting for the diplopia due to proptosis. So when she bent forward, these varices would of course fill up and push the globe forward, giving her a few seconds of double vision and a rather starry appearance to the eye. But as is sometimes the case, these varices were associated with an encephalocele, a bony defect, and this was causing the pulsation of the eyeball. I've seen quite a few of these patients with this combination of orbital varices and various degrees of skull defect. But this is the only one I'd seen with this particular symptom. Much more serious, I remember one patient who developed a intracranial infection, which in fact, when we saw her, she had she turned up in the eye clinic where she was being followed with a bad headache, and they sent her across to me, and she had obvious positive Koenig's and Brudzinski's sign. In fact, she had an extradural abscess which had gone all the way down the spine. So these patients can get into trouble with this. But in her case, she was cured by Velcro. So we persuaded her to buy some Velcro boots, and she didn't have any more trouble. So this is a meningocele associated with varices. This is the woman from Wales, 38. Now, some years previously, when she was pregnant, she had sudden onset of giddiness, headache, double vision, and weakness of the left arm and leg. She was found to have a neutral rigidity again, meningism, photophobia, a left hemiparesis, and impaired upgaze affecting the left eye more than the right. She gradually recovered from all of this, but she was left with hemidystonia, and also a paroxysmal vertical diplopia. This again appeared to occur randomly. It might have been a little bit more likely to occur when she was walking, but again, there was no clear precipitant that we could take advantage of. And it never lasted for very long, no more than a few minutes. It wasn't associated with any subjective vestibular disorientation, such as tilting of the visual of her environment. You'll see the relevance of that shortly, but it was more likely to occur when she was ambulant. She had a mild left hemiparesis and she had hemidystonia, and she also had rather slow vertical upsaccades. And once again, we just waited around, got her walking around until we got an attack. And this is what her eyes looked like during an attack. So this became known as a paroxysmal ocular tilt reaction. Now, the term ocular tilt reaction is interesting because it's the only human pathological feature that I know that was actually first described in normal primates, because Westheimer, who at Berkeley was experimenting by stimulating primate midbrain, and he discovered that a particular region would give rise to this tilt reaction. So physiologically, of course, tilting will occur when the head is moved in the roll plane, as the aviators would call it. And if her head was contrary rotated, the eyes, of course, would remain straight. But here, with the reflexes occurring from direct stimulation of the midbrain oculomotor pathways. Sorry. So this lady had an intracerebral hemorrhage here, and this had affected both the corticospinal pathways, giving rise to this hemiparesis and subsequent dystonia. But this was probably due to a cavernoma. And cavernomas are well known for depositing ferritin, and this may have an effect that results in paroxysmal activity. It's not quite clear. There's a lot of interest in this now with amyloid angiopathy, because patients with amyloid angiopathy, which is on the surface of the brain, get paroxysmal episodes, and no one's completely sure why this is, but it's clearly related to blood products in some way. And we tried a lot of things for this lady, but we eventually cured her with acetazolamide. And as far as I know, she's still taking it. She very, very kindly agreed to come all the way back up from Wales and to come off this acetazolamide so that we could explore this in more detail. And we found that the paroxysmal ocular activity, which we were recording with search coils, coincided. It was exactly synchronized with some paroxysmal activity occurring in the affected limbs. So in addition to this resting, if you like, dystonia, which was always present, there was also paroxysmal activity in the limbs. And what we often saw that there were a number of jerks in her upper limb, a series of jerks in her upper limb, and then the eyes would go into this position. So she didn't respond to carbamazepine, doesn't seem to cure everything, but she did respond to acetazolamide, and in fact, the attacks were abolished for all the time that she was taking it. And she's never got back to me to say that she's run into trouble. So paroxysmal ocular tilt reaction due to thalamic, subthalamic hemorrhage with hemidystonia, and this so this was published. Well, it's more than 20 years now. So here's a 9-year-old boy who's again got a history of episodes of vertical diplopia, momentary duration. And we had a very good clue here because these attacks mostly occurred when he was watching TV. But there was a little bit more information required because he always watches TV in his bedroom lying on his back. And actually, I'm not sure that this is... No, this isn't going to work very well without the video. But because we don't have any still images of him. But what eventually came to pass was that he has an unusual type of Brown syndrome. Now, classical Brown syndrome in children, this is a restrictive problem with depression of the eye. And in his case, it probably wasn't a typical Brown syndrome because he had double vision. There must have been some other cause for it. But in Brown syndrome in children, generally, they don't have a problem with double vision. But there are acquired forms in adults, usually due to inflammatory conditions in the orbit and so on. Anyway, with him, it was easy. We just advised him to watch TV lying on his front. Right. Now, this one again won't really work very well without the video, but this was a something that I'm sure you've all seen. This was actually a woman in Denmark who had what has been called convergent spasm. So I don't like the term because it suggests an organic cause, whereas this is a functional disorder. The problem is that it's confused with convergent spasm as an adaptive phenomenon. So I just wanted to make the point here. I'm sure you all see such cases. They're referred by the ophthalmologists. So in these cases, generally the eye movements are quite normal when the patient's not being examined. And it's during examination that the patient has the spasm, and you can see meiosis, which indicates that this is a near response. And it is confused with all of these things. It looks like a lateral rectus paresis because generally one eye is watching your finger and the other one is not abducting fully. It's confused with myasthenia. Accommodative spasm is an adaptive phenomenon. So these are patients who usually children who are long-sighted, hypermetropic, and in them the accommodation is to overcome the hypermetropia. So they in them it is adaptive, but of course it leads to the development strabismus. Vergent substitution is very unusual. Some patients who have a horizontal gaze palsy, particularly if they are for some reason not diplopic, learn that they can, in order to get one of the paralyzed eyes off in the direction of the paresis, they can make a vergence action. So if they have a left horizontal gaze palsy, by making a vergence movement, they can get the right eye to adduct and look over to that side. So it looks odd, and it looks very similar to convergent spasm, but it's adaptive. And they tend to be people who are not diplopic for some reason, so you don't see it very, very often. Spasm of the near reflex is not a very well understood phenomenon. Perhaps there's someone here who can talk about it a bit more, but this can occur and is not as a functional disorder. And divergence paralysis, of course, is another thing that can resemble this. But usually in these patients, there's no abnormality when you're not examining the patient. They have perfectly normal eye movements, but when you hold up a finger or a target and get them to move, that's when they start to converge. So last case, this is someone that on a winter's morning, and that is relevant, at 7 a.m., this professor at UCL was driving to his workplace back in the days when we used to drive in London, and he developed double vision. He immediately went to UCL Casualty, had a CT head scan and a lumbar puncture. Everything was normal. And at 9 o'clock, he appeared in my clinic in Queen Square, which is just 5 minutes walk from UCL. And I made the routine question before I examined him. I wanted to look at his glasses. And when he handed them over, I found that he was a high myope. Not only that, but one of his lenses had fallen out of his glasses. I eventually found it in the folds of his overcoat, refitted it in the glasses, and then he was fine. So I think this is an example of someone who is not using their correction, and because of that has developed double vision. And this can happen in other situations as well. This was just rather a dramatic one. Anyhow, I will stop there, and happy to deal with any questions or comments.
Thank you, Dr. Gordon. Such an interesting series of cases. Look forward to our neuro-ophthalmologist to come up with some question.
Dr. Clement here. I'm just curious. Could you share with us why you think acetazolamide worked in that patient with the cavernoma and ferritin deposition?
Yes, that's usually the question I get asked. I have to say, we tried everything else. But you know, it's commonly used in dystonia.
Right.
It is commonly used in movement disorders and dystonia. And that's really, that was the other side of the coin here. So I think somehow this worked better with a treatment for the dystonia. And we have tried to make the point that that dystonia does involve the ocular motor system in some cases, and the mechanism, of course, is not very well understood. But anyway, the answer is I don't know. We tried it because she also had dystonia, and it worked.
Right. Thank you very much. A very interesting series of cases. Thank you very much.
Thank you. Thank you very much. We shall now go on to our next speaker, Dr. Clementine, who's going to be talking on a different case scenario than what we were supposed to see. So it wasn't what it seemed.
Thank you very much, Dr. Chitra. I don't know if you can see the slides, and okay.
Yes, you have to just go to slideshow.
I've taken the liberty of changing the title a little bit in view of the fact that you've decided to call this round the Sherlock Holmes round. I'd like to so thank you very much for inviting me to share at this meeting. With some reference to the great detective Sherlock Holmes, I just begin with an introduction of one of the stories, a case, the Silver Blaze. And this was a case of a missing racehorse called Silver Blaze and his dead trainer. His trainer was found dead. And Sherlock Holmes was called in to investigate this. And with all apologies to all Sherlock Holmes fans, in case you think I'm butchering the story, the clues that were present in this instance were the fact that there was a dog that did not bark, was not heard to bark when the horse was supposedly stolen. Sherlock Holmes had found that upon investigation that this trainer had gone to another town and bought an expensive dress under a fake name. Found at the supposed crime scene was a cataract blade, so there is some relation to all the cataract surgeons. And then there was a peripheral clue of 3 lame sheep on the same farm. And so the solution that was finally put forward and what solved the case was this. The dog did not bark because it knew the intruder. It was familiar with the person who was there, so it did not bark. And this intruder turned out to be the trainer, who was found to have been spending a lot of money on a mistress. And it seemed that he had arranged with a bookie to fix an upcoming race by making a micro incision on the horse's tendon with a cataract blade, which he had practiced before. He had practiced the technique on the sheep, and so he determined that making a small slice would make the animal lame. And eventually it was determined the trainer had been kicked to death by the horse, who had been in a panic when the trainer was trying to do something to him. And the horse had been dyed brown to camouflage its distinguishing features, and the horse had then been found wandering in the neighborhood and had been taken in by a neighbor who was looking after it. And so that was the case of Silver Blaze and the dog that did not bark. Now, what has this got to do with anything we're talking about today? The first case I'd like to share with you is a 42-year-old man who came to us from overseas, a nearby country, and he complained of transient blurring for 6 months, and more importantly, a more constant left eye blurring of vision for the past 3 months. His visual acuity was 6.9 in the affected eye and 6.6 in the good eye. No afferent defect. He had normal color vision. And he had a swollen left disc and a slightly swollen right optic disc as well. So, of course, with 2 swollen discs, we proceed straight to neuroimaging to determine if there's raised intracranial pressure. His blood pressure was normal, but the MRI was normal. Lumbar puncture showed that opening pressure was 33 centimeters of water with normal CSF constituents. Since nothing else was found, there's no other cause for this illness, we treated this as idiopathic intracranial hypertension, and he very quickly returned to his work overseas and was followed up back in the country where he was working. A couple of months later, a year later, he returned and his vision was now 6.45 in the right eye and 6.9 in the left. This swelling, he has this swelling in both eyes, but he now had occasional anterior chamber cells. Again, the MRI was normal. The CSF pressure was raised and the CSF was otherwise normal. This time, upon further questioning and inquiry, because his name was a little unusual, we found out that although he worked in a neighboring country, he was from Turkey. And I'm not sure why that triggered off a series of more questions, but eventually determined that he had a history of oral and genital ulcers. And then the HLA-B51 was positive, and we determined that he had Behçet's disease according to the criteria for Behçet's. He was treated with IV methylprednisolone. He had good recovery of vision, but then he returned to his home country, and we did not see him for any further follow-up, but presumed that he had recovered. Now, case number 2, 14-year-old boy who had floaters and a rippling effect in the right eye, normal visual acuity, normal color vision, no afferent defect, right optic disc swelling with a very mild visual field defect, normal looking macula. Again, a normal MRI. But on further investigation, because everything was normal, we decided we'd do a fluorescein angiogram, demonstrate this leakage. We saw capillary leakage as well in the rest, the retina in the right eye, and some peripheral leakage in the left eye as well. And this led to a search for other signs and symptoms of disease. And then the history appeared that he had had an erythema nodosum-like rash on the arm, recurrent testicular pain, and recurrent mouth ulcers. And again, the definition of Behçet's disease was made, and he was successfully treated with prednisolone and adalimumab. Now, we know Behçet's disease is typically diagnosed by not by any serology, but by a constellation of clinical signs. And what is unusual in at least the first case that we had was that he presented with isolated intracranial idiopathic intracranial hypertension, and there have been some cases of this reported for neuro-Behçet's. And other causes of disc swelling in Behçet's may be optic neuritis, optic disc vasculitis, or they may just be related to the anterior uveitis. The challenge in these two cases, of course, the clue was always there. It was just not discovered till later on, and that is the history of recurrent oral and genital ulceration. So highlighting once again the importance of getting a very complete history, which we sometimes don't do when we see a disc swelling with visual loss. And it's only when we discover the MRI is completely normal and that we start to search, though we probably should start the search by taking a more thorough history in the first instance. The third case I'd like to share is a 49-year-old woman with no previous medical history who presented with a central scotoma in her right eye for 5 days. And the vision in the right eye was hand movements only. That left eye was 6/7.5. She had a right afferent defect, and the doctors who saw her first said she had right optic disc swelling with Roth spots. And helpfully, they've taken a photograph, and you can see some of the retinal hemorrhages out in the temporal periphery of just beyond the arcades inferiorly on the right eye. But there is a whitish lesion on the optic, on the swollen right optic disc, which was originally thought to be a cotton wool spot. Accordingly, the initial team thought that this might be an optic neuritis of some sort, and proceeded to do an MRI, which turned out to be this is also to show that in the OCT of the macula there was some subretinal fluid tracking under the macula as well. So there was an MRI that was done, no contrast enhancement, a workup for the usual the common antibodies which we these days tend to send almost all the time, as well as some other autoimmune studies were negative. And initially the serology for syphilis and tuberculosis were both negative. She was started on IV methylprednisolone about 6 days after she presented. These investigations had been done, and there was some improvement in the submacular fluid as well as the swelling of the disc. 10 days after presentation, another blood test came back, and that was for Bartonella. And retrospectively, the history appeared that this patient does keep cats and probably had been scratched by one of the cats. With further treatment of the doxycycline, the disc swelling resolved, and at no time did the macular star appear, even though we had a lot of serial photographs. And although the disc swelling did resolve, unfortunately, her vision did not recover. Case number 4 is a 23-year-old man who presented with a sudden painless loss of vision in his right eye, and this had been preceded by a 2-day history of fever and cervical lymph adenopathy, which his GP had treated him with Augmentin, assuming this to be upper respiratory tract infection of some sort. Visual acuity at presentation was counting fingers in the right eye and 6/6 in the left. He had an afferent defect, normal anterior segment examination the right, and the left eye was normal on the posterior segment examination as well. The right eye showed a swollen disc, with, again, on the OCT macula, some intraretinal and subretinal fluid. And of course, there was a visual field defect in that right eye. Again, it was assumed to be optic neuritis, and he had an MRI of the orbits and brain, which was again normal. His other blood work showed that the total white was elevated, and the ESR and CRP were also elevated. Investigations for NMO and MOG negative. And this time, somebody thought to send off for Bartonella and Borrelia and as well. I think they were just trying to cover all the bases, but everything was negative. And the fluorescein angiogram just showed disc leakage on the right eye. Finally, after a couple more days, someone thought to take additional history and found that he had been scratched by his pet cat. And the Bartonella serology repeated again and came back a week later as being positive. This one had a happier ending. You can see that at about that time, the macular star has now appeared. He was treated with doxycycline again, and his vision recovered to 6/9 in the right eye. You can still see some of the residual exudates in the right eye. Now, Bartonella, it's thought to commonly and classically present with a neuroretinitis, but we note that at least in the first case, the macular star did not appear. In the second case, it was delayed. It can present as an optic neuritis, but some recent reports have shown that discrete retinal or chororetinal lesions, white retinal or chororetinal lesions, which are thought to be retinal choroiditis, may be more common than the macular star, which you may have noticed in that first case, that white lesion at the disc, right? The more sight-threatening presentations would include intermediate uveitis, retinal vasculitis, and vascular occlusions, and retinitis. The less common posterior findings may include granulomas, choroiditis, angiomatosis lesions, and serous retinal detachments. The challenge is this, right? At the outset, the disc swelling looks no different from an optic neuritis, and the macular star may not appear till later. OCT may show subretinal fluid, but again, subretinal fluid is also present in your typical optic neuritis, as well as ischemic optic neuropathy and papilledema, right? Systemic signs such as a lymphadenopathy or the prodromal fever may be absent, and the history of contact with cats, keeping cats being scratched by a pet, is frequently not offered initially. And initial seronegativity at Bartonella is possible, and not every patient is initially tested for this. So the question is, one question we have in mind is it reasonable, necessary to order Bartonella serology for every swollen disc without contrast enhancement on MRI? And the answer, maybe it's better to take a good history and ask whether they keep cats before you do that. But again, that's sometimes missed out. In any case, most cases of the neuroretinitis are self-limiting and have good recovery, but occasionally you will have poor visual outcomes linked to either poor vision at presentation, the severity of the initial involvement, retinal lesions, severe disc edema, and extensive macular involvement, and perhaps a delay in diagnosis. So, back to our original premise and the link with Sherlock Holmes. What would Sherlock do in these cases which present with an initial with features that look initially like an optic neuritis, but the important investigation of the MRI does not show any optic neuritis, or in this case, dog does not bark? And I think Sherlock would just reevaluate all the evidence and do serial observations and derive more clues. So the dog did not bark. In these cases, none of them had contrast enhancement of the optic nerves on the MRI. It's a relevant negative. 3 sheep were lame, and although this seems peripheral in the case, but information suggesting conditions linked to a similar cause, like the presence of systemic features, should not be ignored in all patients presenting with a disc swelling when taking the initial history. So signs of autoimmune disease, signs of infection. These are important to consider and not to ignore. So 3 lame sheep are important. The horse had been dyed brown, and some signs are delayed or camouflaged, like the macular star and initial negative serology in Bartonella. They may be delayed, and sometimes you'll have to repeat them and continue serial observations and look a little harder in order to find it. And then we need to follow down other leads. For example, Sherlock tracked down the purchase of a dress to determine the motive for the trainer to be taking a bribe. And so you need to gather additional history, sometimes not immediately forthcoming, such as a history of being scratched by a cat. And with that, and with all apologies to the Sherlock Holmes fans out there in case I've butchered the Sherlock Holmes story, thank you very much for your attention.
Thank you so much, Dr. Clementine. I mean, it was not just neuro-ophthalmology we learned, we also learned that you're a great storyteller. You had us wrapped all those few minutes while we were hearing you. It's a special art, actually. So, questions?
Can you hear me?
Yes.
So I've just
Dr.
switched
Clement?
I've just switched to my phone. Can you hear me, Dr. Plant here?
Yes, we can hear you, Dr. Plant.
Oh, excellent. You didn't mention that Conan Doyle was an ophthalmologist.
Yeah.
Yes, I thought I would have run out of my 15 minutes if I talked about Conan Doyle and the original inspiration for Sherlock Holmes, which was this physician in Edinburgh. Yeah.
Well, it explains why that particular instrument was used to.
The cataract knife.
Yes, the cataract knife was most interesting, and happened just at the same time as a friend visiting London sent a photograph of a museum piece showing a spring-loaded cataract knife.
I would make one comment in our recent attempt to provide a classification of optic neuritis. I have called so-called neuroretinitis as prelaminar optic neuritis, and this is based on the fact that in the definite cases, as you say, the optic nerve imaging in the orbit is normal. And this also, the fact that the inflammation is occurring prelaminar also accounts for the star, because any exudate that is produced is an inflammatory exudate, and it therefore has the right lipoprotein content to deposit the star. Now, if you take anterior ischemic optic neuropathy, we've recently looked at that in terms of the subretinal fluid produced there, and it's extensive. In some cases, it's extensive, intraretinal and subretinal, but a star very rarely appears, and if it is, it's likely to be what people have called a macular fan, just a hemistar on the nasal side of the macula. And that's because this fluid is a transudate and therefore does not have the high lipoprotein content of an exudate. So and this must mean that this is somehow an immunologically distinct compartment. So I think that, to me, the essential thing is that as you say, that the optic nerve in the orbit does not show any signs of inflammation. That whether or not the star appears may also depend upon treatment. I just reviewed a case report where one eye had been treated very promptly and the other eye never developed the star, presumably because the production of the exudate had ceased.
Yeah, thank you very much for those comments, Dr. Plant.
Thank you.
I wonder if you also had some thought on the fact that in some of these cases, when the MRI is done, we actually do see some contrast enhancement of the optic disc. at the with the intraocular optic disc, they do show some enhancement of that disc as well. I wonder if that is any help in this discussion on prelaminar optic neuritis. Oops.
So,
Okay. I think we lost the plant again.
so,
Okay.
Clement,
Yes,
I
sorry, I'm here.
interrupt.
I'm here. Yes, can you hear me?
Yes, Dr. Plan.
Yes, yes, but of course you can see that also we're in optic neuritis in MS. I mean, involvement of the prelaminar part of the optic nerve is possible with other types of inflammatory optic neuropathy. What's essential here is that the optic nerve is not involved in the retrolaminar region.
Yes. Correct. Yes. Yes.
Thank
That was
you.
what I was referring to.
Because of,
Yeah. Okay. Thank you.
because of paucity of time, we need to move on. And I invite Dr. Pradeep Sharma to give his talk on paralytic strabismus. And after the first 3 amazing talks, it's a tough act for him to follow. So we look forward to your talk, Dr. Pradeep.
Thank you, Dr. Chitra and Dr. Murli, for giving me this opportunity to be here. I think it's a tough time because I have to wrap it up in 10 minutes. And I hope we just do an update on this. So as we see, third nerve palsies has been talked about neuroimaging earlier, but just to make it simpler, what we usually follow is that if it's pupil sparing third nerve palsy, we need to investigate the ischemic vasculopathic causes in the management and look for simple culprits like the blood pressure, blood sugar, lipid profile, homocysteine, and also the ESR and CRP, because some form of giant cell arteritis may also present as third nerve or sixth nerve palsy. So that should be kept in mind. And then specific investigations should be done as required. Some of these cases may also require imaging, and we'll talk about what. Myasthenia gravis should also be ruled out. But the main thing is that they may be again be pupil sparing. And if you have an unexplained pattern, the simple thing which I follow is in the clinic, the ice pack test, which is very effective. It almost like 70 to 80% cases, and just takes about 2 minutes to rule out myasthenia, ocular myasthenia gravis. So pupil sparing cases, we should investigate for the ischemic causes, as I said. But if there are no pupillary involvement, look for delayed pupillary involvement in the subsequent 5 days and recheck every 4 to 6 weeks. Usually the vasculopathic third nerve palsies start recovering in 4 to 6 weeks time and fully recover by 3 months. If there is no recovery happening in the first week, or the pupil dilates, or additional neurological features are happening, or there are aberrant regeneration, or there is a progress of palsy, do not hesitate to do an imaging. So imaging should be done in these cases. And if there is a third nerve palsy with pain, specifically an MRA would be called for. If pupil is involved but imaging is negative, then even a neurological consultation and a lumbar puncture should be done. So when to do imaging, that's what should be kept in mind. I think we had a very nice talk by Dr. Srinivasan on the details of the findings. I would not go into that, but these indications we should keep in mind as a clinician. Cases which have a pupillary involvement, of course, we should be looking for, there may be intracranial space occupying lesions. And as has been talked about, why there is a pupillary sparing, because of in the vasculopathic, because of the nerves which are having blood supply outside. The aneurysms can also be causing the third nerve palsy. But imaging can sometimes also tell us about those cases which may be considered as sixth nerve palsy but are not true sixth nerve palsies. Now, this is a deviated muscle and not a paralysis of sixth nerve, as has been shown by imaging. And these are cases of high myopia, and these also should be kept in mind. They may be the sagging eye, the heavy eye, or the knobby eye, which will be picked up on imaging. So another indication for imaging would be these conditions, which will reveal the diagnosis. The congenital cranial degeneration disorders are other conditions in which imaging does help, and these are actually paralytic strabismus, not acquired, but in the congenital phase. So these also should be kept in mind, and here the high resolution imaging does help in finding out the problems in the third nerve, or the in case of Duane's retraction syndrome, the sixth nerve, the third nerve in cases of congenital fibrosis extraocular muscles, and the Mobius sixth nerve. So these conditions I would just like to keep in mind for the people. Once we have a diagnosis made, how do we manage? Now, in third nerve palsies, we usually follow up every 6 weeks for recovery. If there is no recovery in 6 to 9 months, then only surgical management is thought of. But short of that, can we do something? Yes, Botox has been talked about, and it has been there for quite some time, but its role is limited. Even the recent study from the Korean journal, which has talked about the Botox, it has shown that in 60% of these cases which were vasculopathic recovered. So it's majorly the vasculopathic cases which are going to recover in 3 months' time on its own. So it doesn't serve much. But if, yes, the patient wants an expedited recovery, then Botox can be injected in the contralateral muscle to have an effect. But these effects are always short lasting, maybe by 3 months or 4 months, they disappear. Another thing which has come in the purview is the bupivacaine injection. So the bupivacaine, which can be, but the studies have shown that we require to have a higher concentration of bupivacaine than what we normally use. The injected volumes have to be more than 1 ml, but then that becomes a problem injecting into the muscles. The overall change in the ocular alignment is not very good. It's maximum seen about 10 to 12 prism diopters. Even studies done by Dr. Alan Scott did not appear to be very promising. So it's just an adjunct in addition to the Botox that he was advocating, and not on its own as a therapeutic measure. So if there is a third nerve palsy, what do we do? Mostly we do surgeries. And if the eye crosses the midline, we do recess resection. Nowadays, instead of resection, you may do plication. We do not go into the videos. Recently, the MR mini plication is another additional thing which helps us in situations which are in between the cases which require a full plication, but we can just use a central suture, 4 millimeters or 4.5 millimeters, and then give an additional effect to the paresis. Relieving the FDT is very important. So many people I see have done cases of third nerve palsies which have failed, partly because they have not seen the post-operative FDT being fully released. You don't have to go by the recession amounts. It has to be an FDT to be relieved fully. Large LR recessions are called for in these cases, maybe to the extent of 18 to 24 millimeters of LR recessions. And that is why sometimes we do a periosteal anchoring of the lateral rectus. So like in this person who was himself a doctor, I did an LR recession of 24 mm and an MR plication, which turned out to be effective in his case. Cases which have been operated elsewhere, we have sometimes explored and then do a re-recession of more than 25 mm, and that works in these cases. So what do we do in cases in which the eyeball doesn't move beyond the midline? The things which have come up recently is the transposition of the lateral rectus, the split lateral rectus medially transposed, or nasal transposition of the split lateral rectus, NTSLR. And this is a very effective procedure which is done in cases of third nerve palsies in which the eye does not cross the midline. Cases in which there is a hypertropia preoperatively, we have done a full transposition of the lateral rectus without splitting inferiorly, and that also yields very good results. So that is something which can be kept in mind. You need not always split the lateral rectus. You may transpose the lateral rectus full width inferiorly if there is going to get a correction of hypertropia in addition to the exotropia. Cases which have a pseudotosis may require a contralateral superior rectus weakening, a fixation duress procedure. And cases in which both may be done in, that means the NTSLR as well as the fixation duress procedure to correct both the problems in third nerve palsies. Cases which have a very severe exotropias of 90 prisms, we have done periosteal fixation of lateral rectus and also sometimes a periosteal anchoring of the globe medially to correct the exotropia of these large amounts. Aberrant regeneration requires a different management, and these third nerve palsies, we have to look for each case individually. Some cases like this particular individual has no exotropia in the primary position. The aberrant problem is only of the lid. So this case only needs counseling, and we may not do any squint procedure in these cases. But cases in which there is an exotropia, it's worthwhile to operate on the contralateral eye to take advantage of the aberrant innervation to correct the ptosis in addition to the squint. Now, this is an individual who had a left third nerve palsy in which there has been a contralateral eye done, and you can see that the ptosis also has been corrected after the squint surgery. Cases in which there is an acquired inferior division third nerve, we may do an inverse NAP procedure, a modification in which what we nowadays do is no recession of the lateral rectus which is transposed, just the medial rectus is resected and transposed. So this modification works well and increases the inferior tonus as well as corrects the exotropia. So this is a modified inverse NAP procedure in a case in which a right lateral rectus has been reinserted at the inferior rectus with no recession, and the medial rectus has been resected 6 mm to correct the exotropia and also improve the deviation in down gaze. Cases may also be improved by some other procedures like what we have the Scott procedure in the contralateral eye. This is another newer advance in the squint surgeries that may help us correct the incomitant strabismus which is there in these cases. By correcting in specific direction you want a correction, you can use the Scott procedure. Like in this case, a Scott procedure, resection of 6 mm and the recession of 12 mm on the lateral rectus of the contralateral eye has corrected this incomitance. So important points to remember: deviation in the primary position, look for incomitance, look for the fixing eye for the target deviation. If suppose there is an eye which has no vision, you may have to choose the eye which is fixating. If it is a paralytic eye, a larger correction may be required. FDT for the LR is very important to keep in mind at the end of the surgery, and you may require to do supramaximal recessions in these cases. An option of contralateral muscle surgery should be kept in mind. In 6 nerve palsies, we are little fortunate because we have the vertical recti which are intact, unlike the third nerve palsies. And here we may use the transpositions of the vertical recti, either a full tendon width or a partial tendon VRT. Or nowadays we have the Nishida's procedure or the belly transfers, which can help us in correcting the cases which cannot be corrected by refresh and resect procedure alone. So here there is a non-adjustable partial VRT, and this is showing you a cross-acting VRT to enhance the effect of the vertical transpositions. So these are the advances which we are nowadays following in correcting these cases of paralytic strabismus, which are large angle deviation in primary position, to correct the primary position as well as to improve the abduction in cases of 6 nerve palsy. The modified Nishida's procedure or the belly transfer of the vertical recti without splitting the vertical recti and without disinserting the vertical recti is a good advance to make use of, as it doesn't sacrifice the anterior segment blood supply and gives the vectorization of the vertical force. So these are cases in which we have achieved the correction. There is a review which our group had done of vertical rectus transposition procedures for lateral rectus palsy, a systematic review. But mind you, the important thing is that there is a lot of variability as per the case, also as per the surgeon and his technique, that the results may have a lot of variation. Supraoblique palsies, we have to remember that we can correct it in different way depending upon the involvement, and the NAPS classification comes handy in these cases. Remember to keep these things in mind, that in which deviation, in which gaze is maximum and which procedure we would like to do. I think with time being constrained, we'll not go into the details, but just keep in mind that different procedures are available to correct these 6 nerve, the 4th nerve palsies. Whereas this is an anterior. I think the anteronasal transpositioning is very good procedure for correcting very severe inferior oblique overactions in cases of the supraoblique palsies. In cases which are severe supraoblique palsies, one may do the Harada-Ito procedure, which corrects the torsional component. In such cases, usually the vertical component is not much, and this yields very good results. Recently, I think there are some people like Jonathan Holmes, who has been talking about doing a resection of the supraoblique tendon rather than just an advancement. So just to cut the story short, we have to be a squintellectual to keep the individual case in mind, what is the requirement of that particular case. And mind you, we can usually achieve to correct the binocular alignment in at least in the primary position and in the down gaze, if not in all the 9 gazes. And that should be our goal, to restore the binocular vision and stereopsis. Thank you for this present time.
Thank you so much, Dr. Pradeep. You know, you're always the best. Can you stop sharing? So,
Yeah.
Murli, can you ask some questions?
Yes, sir. Sir, regarding the LR to MR transposition, there have been some reports of a paradoxical severe undercorrection. So how do we avoid it, and what do we do in case we have a severe undercorrection after an LR to MR transposition?
So as I said, Murli, that this is depending on the technique, that how are you doing. And if you have a lateral rectus, usually the lateral rectus is going to be little longer compared to the on nasal shift side. When you transpose it, you need to sometimes do a cross section of the split ends. Do I make myself clear? That in that case, what we do is the upper end of the lateral rectus, I would bring across on the inferior end of the medial side, medial rectus, and the inferior end on the superior side. So there is a cross section which will give us the vectorization of the force. Some people have also done a Foster augmentation on these cases. At the end of the surgery, you have to see on the table that you have achieved a 10 prisms of overcorrection in these cases. Then you do not usually have an undercorrection.
If the FPT is moderately positive, can we still do a LR to MR transfer? Or?
Yes, if it is moderately positive, the LR transposition can be done. If it is, unless it is a very severe tight, it's possible to do a nasal transposition of the LR. In such cases, you may not have to do any vectorization because these are already tight lateral recti and they will yield overcorrection. So you have to be careful that you may rather do a recession of these lateral recti on the medial side. So on the table, again, you will have to see that are you doing an overcorrection of more than 8 to 10 prisms? If that is there, then recess these two limbs so that you do not have a esotropia later on.
Thank you. Thank you, Dr. Pradeep. Thanks a lot. We shall go on to our next speaker, Dr. Durga Priyadarshini, who's a Senior Consultant Neuro Ophthalmology at Shankar Nethralaya, Chennai. And she is going to take us on to an interesting topic, optic neuritis. On to you.
Thank you, ma'am, for the kind introduction. Just a minute. Just having...
You won't have any problem this time.
I have to go to the advanced.
And then I think it was the screen or something.
Screens. No,
Screens.
Screens was not showing up. Slides as it's not coming now.
Advanced, basic, and screens is available.
No. She doesn't have basic. She has advanced
Basic
only.
not there. Advanced, and it's video option. No slides.
Slides.
No, presentation is open.
Yeah,
No,
presentation.
slides. Go to slides.
Yes. May I present? I mean, next actually. I think I have to close my presentation and then open because it's not showing up in the.
Oh, okay. We go on to our next speaker, Dr. Shikha Basi, who's going to be talking to us on OCT and OCTA in Neuro Ophthalmology. Dr. Shikha, you have not been given a moment to think. Sudden surprise. So on to you.
Thank you, ma'am. I'll just share my screen. Thank you for the kind introduction also. I am supposed to... Am I sharing my screen?
Yeah, yes.
Yes, ma'am, it's visible.
It's visible. Yeah, it's full screen now?
Yes, ma'am. Yes, ma'am.
Yes, it's full screen now.
Yeah. Thank you, Chitra ma'am. Thank you, Murli, for inviting me to give this talk on optical coherence tomography and also OCT angiography in neuro ophthalmology. So I will not be talking about the basics of OCT, though I'll touch upon the basics of OCTA. OCT I have covered many times in many talks, and it's also available on the internet. So I'll just look at what's new in this field, especially about papilledema diagnosis, pseudopapilledema, optic neuritis, and we'll cover a little bit of OCT angiography basics. So in papilledema, we look at how what's new in when we look at OCT in patients with raised ICP. And this paper, which was published this year, we concluded that patients with raised ICP, they had a correlation, the retinal nerve fiber layer thickness, especially in all four quadrants, had a weak positive correlation, and the GCIPL layer had a weak negative correlation with the CSF opening pressure. And the EDI descriptive features.
Well, you have to have this. Oh, you brought this. Okay.
Can you all, everybody mute their...
Yeah, thank you. The EDI descriptive features on OCT also varied with the ICP. So where this paper is pointing towards is that somewhere in future, OCT can replace the lumbar puncture to check the CSF opening pressure. The OCT findings can indicate not only it can confirm the diagnosis of papilledema, it can indicate, hint towards what's the CSF opening pressure. So let's, as I said, we looked at the descriptive features of the EDI images in patients with papilledema. In early papilledema, you could just have a little bit of nasal elevation where it can get can be confused with pseudopapilledema. So it might not be very helpful, at least in early papilledema, to diagnose with OCT alone. As the papilledema establishes, we notice some honeycomb appearance in a few of the patients. And as if the ICP is very elevated, and there's significant papilledema, there is wavy deformity in the peripapillary region of the inner nuclear layer and the outer plexiform layers. And you can also notice inward denting of the RP and Brooks membrane in these cases. The inward denting of this Brooks membrane RP complex is more evident when the ICP has been raised for very long time. Here you can see it's almost a champagne cork optic atrophy because of chronic papilledema. Another feature that we noticed was that in chronic papilledema, which has been there for very long, there were some cystic spaces noted in the inner nuclear layer, along with the wavy deformity, and a forms which has a very, it's kind of a compressed forms in the peripapillary area, where it can be confused with a peripapillary CNVM, which can also present with cystic spaces in the inner nuclear layer. We look at how to differentiate between forms and peripapillary CNVM in a few slides further. So next we see what are the findings in pseudopapilledema when you do the OCT. This is our last year's work on the same. We looked at the OCT images of confirmed cases of pseudopapilledema which had been followed up and confirmed had a confirmed diagnosis of pseudopapilledema. So some of them had a very easy diagnosis. The drusen could be picked up not only clinically. On OCT, you can, the consortium has already defined, the group has defined how the drusen appears on OCT. It is a hyporeflective with a hyperreflective margin structure, which can be seen superficially or into the depths of the optic nerve. So not every case has of pseudopapilledema has a drusen, which can be picked up on OCT. At times you can see horizontal hyperreflective lines, and these are also probably precursors of optic nerve head drusens. You can see some of the patients had this finding. And some of the patients did not have either of the two, and they just had forms, especially in children. They could just present with forms. Here again, it can be very confusing. As I said previously, in early papilledema, you could have something very similar. So forms kind of cannot confirm the diagnosis of pseudopapilledema, but forms are seen in pseudopapilledema too. So let me show you how to differentiate between forms and peripapillary CNVM. We've published this too in Neuro Ophthalmology. This is a case of morning glory disc, and you can see it has a peripapillary subretinal fluid. If you do OCT, you get so much more information. You can see the fluid here. And what you can see is here, this forms, which has two structures actually of different reflectivity. If you see, this is a very white thing in continuity with the outer retina, and there's a very grayish kind of a thing in continuity with the inner retina. So this is actually the forms, and this is actually the CNVM. You can see that CNVM on the other side, it's active. It's got a lot of fluid around it. So it's an active CNVM here. You can see it very clearly what I'm trying to say. I have put the color here. So this is the CNVM and this is the actual forms. Why does one need to differentiate? Obviously, the CNVM is active and needs anti-VEGF injection, whereas forms does not require the same. Now coming to optic neuritis, we know in the acute phase of MS optic neuritis, whether it's papillitis or no papillitis, there is exoplasmic flow stasis because of which the RNFL is thickened and it appears like this, either all four or, two quadrants may be a little thickened. And over a period of 4 weeks, it sets into thinning, and this thinning is in the temporal quadrant in the case of MS optic neuritis, and it involves the superior and inferior quadrants in NMO spectrum disorders. Now, having said that, RNFL thickness does not correlate with the visual function of the eye. Whereas the ganglion cell thickness, it correlates not only with the vision, it correlates with the visual fields also. And this thinning can occur as early as 2 weeks after optic neuritis, and this thinning is very severe and significant in patients with NMO spectrum disorders, related optic neuritis. So with that, I think I'll cover a little bit of basics of OCT angiography, which I've never covered before. And it's important, if you have to utilize the technology to pick up the pathology, to understand how it can change in diseases, we first need to know what is the normal, how does a normal optic nerve retina look on this technology. So basically what it captures is, it captures the superficial vascular system, it captures the deep vascular system. The superficial system is in the nerve fiber layer and in the ganglion cell layer, and the deeper system is in the inner nuclear and outer plexiform layer. And you can also see the choroidal circulation. Now, I've taken this from these beautiful articles in the scientific reports, and the previous one was from retina. So this shows that this is the end face image of the OCTA, and it's going right through the disc and then the macula and the periphery. And it is, this is the end face image, and this is the color composite cross-sectional image. And here you can see the flow, blood flow in the retina, and also the red one is in the choroid. Now, this end face image and all this is the what you're getting. It is the descriptive data. We need objective data if we have to utilize this technology to diagnose diseases. So to get that, this paper has defined how to capture the vascular density in 4 different places. One is right next to the disc, that is the peripapillary area. Next is perifoveal, here in the inner green circle, and then there is parafoveal, that is in the blue circle, and then right in the periphery. So you can capture what's the actual capillary vascular density in these areas. In all 4, we'll talk about which 4. Now, there are, as I said, these 4 areas, they picked up that there were peaks in the vascular densities. Now, in the peripapillary area, the peak is in the nerve fiber layer, and that is what is called the radial peripapillary capillary plexus. And in case of parafoveal and perifoveal area, this peak is in the ganglion cell layer, and where it is called the superficial vascular plexus. So actually, this is also what is in the NFL in the peripapillary area is the superficial vascular plexus. And then there is another peak which is at the at the inner margin of the internuclear layer, which is called the intermediate capillary plexus. And there's another one which is at the junction of internuclear layer and the outer plexiform layer, which is called the DCP, or the deep capillary plexus. Now, this happens in the perifoveal and parafoveal region, but in the periphery, the deep plexus and the ICP is one. It's kind of a single peak here. So now in all these four places, in all four vascular plexus, you can capture not only the descriptive image, you can understand in a normal eye, the radial peripapillary capillary plexus appears like this. You can see the vessels. The superficial plexus appears like this. This is the intermediate. This is how a normative in a normal eye, the appearance of all four capillary plexus is. Not only that, the paper has given the actual vessel density in all the plexus and also in all four locations. So with that, we are armed with the normative data. Now let's see what the neuro-ophthalmologists across the world, how they have utilized this information. This is by Dr. John Chins. This is from Mayo, I think. This review article, and it says that the reduced vessel density in patients with optic neuritis because of MOG and also basically NMO spectrum disordered optic neuritis, the vessel density is reduced not only in the peripapillary area, but also in the at the macula, in eyes which have had optic neuritis. And it afflicts basically the superficial retinal capillary plexus. Similarly, in patients with IIH, these are very recent publications. The OCT angiography has been utilized, and in these patients, what they have noticed is that the peripapillary microvascular measurements, they're correlating with the GCIP layer thickness. We all know GCIP layer thickness it correlates with the optic atrophy. Basically, if the optic disc is going into atrophy, this layer is going to be very thin. So basically, peripapillary microvascular parameters may be an early indicators of optic nerve atrophy setting in IIH patients. This is what this article said. Now, these are the times of artificial intelligence and machine learning. So this latest from JNO says that if you feed the computer whatever the descriptive and the objective data from the eyes afflicted with NAION and also with optic neuritis, and obviously we have the normative data, then the computer can tell you whether and you've done the OCTA, then the computer can tell you whether the patient has had NAION or the optic neuritis. So that's where we are going with both with OCT and OCTA. This combination, the combination with machine learning, I think that will really make the diagnosis very easy of all the afferent defects in the eye. So with that, I'll just end with this very interesting case of functional visual loss, where I utilized OCT to diagnose it. This is a case of a gentleman who came to us with a history of vision loss in both the eyes since past 2 years. He's had retinal detachment and surgery for the same in the right eye. And his vision that eye is supposed to be no perception of light, left eye 624. His pupil was a little sluggish on the right eye. He had retinal detachment surgery, but there was no RAPD. This was healthy. Visual field was constricted, very unreliable. This is the fundus. We all know this is functional, right? Everything, there's no RAPD, but I need to document. I need to document with some tests, that I need to confirm the diagnosis. So this is the fundus. You can see that there are changes of post-RD surgery, but the disc is fairly normal. And this side, the other eye, the visual feels like this. So I advise VP. I was very sure the VP is going to be near normal or normal, but this is how the VP came. There are absolutely extinguished waveforms. In flash, VP is extinguished in both the eyes, and the other eye, the VP is showing delayed latency and reduced amplitudes in the left eye. So it's surprising that 10 PLI we could do the flash VP. So we advise for OCT and OCT, the macula, everything, we can see that it's absolutely normal, that the ganglion cell. So if I want some supportive technology to confirm what clinically I've picked up, I think the OCT is supporting me. So VP, though, is supposed to be objective. If the patient defocuses or something, can change the findings. So with that, I think I'll stop.
Thanks a lot, Shikha. You made it so basic and so simple, and something which we can understand and connect in our practices. Some very simple question I have. If you see that sectoral loss of capillaries in OCTA, AION, could it be just secondary to an RNFL loss and not a specific finding?
No, so yes, ma'am, it can be because of that, because after all, the vessels are supplying RNFL. So if there's no RNFL, there is no blood vessel required there. So it kind of parallels the RNFL loss. The OCTA is going to show what OCT is showing. So one finding that I haven't published as yet, but I'm working on, is luxury perfusion in ischemic optic neuropathy, which can be, an added information to the sectoral loss of RNFL. The other side, if there is luxury, you can pick up luxury perfusion on OCTA, then that kind of confirms. That's an extra added thing.
Murli, you have anything to add here?
Yeah. So it is said that a serial loss of ganglion cell thickness is kind of a measure of disease activity in multiple sclerosis. So would you agree with that, and do you use it in your clinical practice?
Yeah. So in multiple sclerosis, the loss, unlike NMO spectrum disorder, the loss of RNFL and GCC is, it's not attack related. Even if the patient has not had optic neuritis, the patient, if the disease is active, if MS is active, is going to have RNFL and GCC thinning. So yes, I'll agree. If the patient has an active MS going on, just like Alzheimer's and Parkinson's, the RNFL is going to show thinning.
Thanks. Lads, we are really running short of time, so I'm going to go on to our next speaker, Dr. Vidna Shah, who's the Chief Neuro Ophthalmology Services of the Arvind Eye Care Hospitals.
Madam,
Sorry,
I think Durga is on line, madam. She's shared her screen.
Oh, okay. Sorry, Durga. Sorry, Dr. Vidna.
Sorry,
We'll call you. Yeah.
No problem.
Yeah.
Okay, can I start?
Yeah, start.
So let me thank Chitra ma'am and Murli sir for giving me this opportunity. So my presentation for today is what's new and important in optic neuritis. Oh, it's not moving. Yeah, so optic neuritis is an inflammatory disorder of the optic nerve, which can be due to demyelination, inflammatory or infectious causes. And the most common is due to multiple sclerosis as per the Western literature. Optic neuritis in Asian population has been reported to be atypical, unlike the Western population. But the understanding of optic neuritis is rapidly changing with the discovery of the newer antibodies and development of latest investigations and the updated diagnostic criteria. So let me start with a case. A 30-year-old male came with the complaints of sudden painful drop in vision in the left eye for the past 4 days. His vision in the left eye was counting fingers close to face. Pupils had RAPD. The color vision was profoundly lost. And this was a dispatcher, had a frank disc edema in the left eye. The visual field in the right eye was fairly okay. The left eye had advanced field loss. So the atypical features here were a male patient with a profound loss and a disc edema. So it was a case of acute atypical optic neuritis, and the MRI brain and orbit was done. Brain was normal, but the optic nerve had signals and optic nerve enhancement, along with perioptic nerve sheath enhancement was also noted. So the blood workup was done, which came out positive for MOG antibody, and it was a case of acute optic neuritis secondary to MOG associated diseases. So little bit of epidemiology. Indian studies in the past, like dating back to 1985, they have noted that the MS constituted to around 0.3 to 1.5% of the neurology admissions in the hospital, and the prevalence of was approximately 1.33 per 100,000. But recent studies have a population-based survey, especially done at Mangalore Demyelination Registry, have shown that the prevalence was 8.3 per 100,000 for MS and 2.6 per 100,000 for NMO spectrum disorder. And other studies have also reported that the presentations here in our population is all atypical with a poor prognosis. And another study from the same institution, they noted that which was much later, more recent, noted that NMO spectrum disorder represent 20% of all the demyelinating disorders in South India, out of which 30% were aquaporin positive and 20% were anti-MOG positive, and 49%, close to 50% were seronegative. Another recent study from our institution, we noted that around 28%, was for a shorter duration, where we noted that around 30% were positive for MOG and close to 10% were positive for NMO, and 56% were seronegative, negative for both the antibodies, and only 5% were diagnosed as MS. So a significant number of them were double negative, who presented only with optic neuritis, but no other features of MS or NMO spectrum disorder. So let's see how to differentiate typical versus atypical neuritis. Typical optic neuritis is a specific clinical pattern which is usually related to demyelinating lesion, which could be isolated or associated with MS. And the features are usually seen in young female. They have unilateral presentation, painful attacks, and this onset is usually subacute, and they have subsequent improvement within a few weeks of onset, and the presentation is usually RBN. Whereas atypical optic neuritis, the cause could be various inflammatory, as enlisted in this table, or infectious also. And the features are, they could present in extremes of age, vision loss is usually profound, painless attacks, bilateral involvement is noted, and severe disc swelling or macular exudates can also be noted. So moving on to the different clinical, let's see how to differentiate the different types of optic neuritis. Initially, NMO spectrum disorder was considered as a variant of MS, but now it has been designated as a separate entity of demyelination, though they have some phenotypic overlap. So this is a table which differentiates the three types of major types of optic neuritis, that is MS optic neuritis, aquaporin positive, and MOG positive optic neuritis. Usually the age is much younger in MS compared to aquaporin and MOG. There is female predilection in MS and aquaporin positive, whereas in MOG there is not much of sex predilection. Eye pain is usually less frequent in NMO spectrum disorders, And bilateral simultaneous involvement is also seen more commonly in NMO spectrum disorders. The recurrence and rapid recovery is noted more in MOGAD, and steroid dependency is also noted in MOGAD diseases. And visual outcome is usually poor in aquaporin positive optic neuritis when compared to MS and MOGAD. Other than optic neuritis, symptoms like ADEM is frequently seen in MOG optic neuritis, and area postuma, where the patients can present with hiccups or vomiting secondary to dorsal medullary lesions, are usually seen in aquaporin positive optic neuritis. And longitudinal extensive transverse myelitis are very classically seen in aquaporin positive optic neuritis. And the pattern of optic nerve involvement in MRI can give us diagnostic clue. Usually the segments are short in MS optic neuritis, whereas long segment involvement is seen in aquaporin positive optic neuritis. And long segment, along with the perineural sheath enhancement, as we saw in one of my patient now, and how Dr. KGS sir showed very beautifully. So that is more commonly seen in MOG optic neuritis. So moving on to the next important thing, that is autoimmune conditions which could be associated with optic neuritis, which is important for us to know. Whereas there are various systemic autoimmune diseases which can present with optic neuritis, like Sjogren's, sarcoid, SLE, antiphospholipid syndromes can manifest as optic neuritis during the course of the disease. And optic nerve involvement in these cases could be immune mediated or sometimes due to vasculitis, leading to ischemia of the optic nerve. And these cases may be they could be a manifestation of NMO spectrum disorder rather than the autoimmune disease itself. So always serological workup, including autoimmune and NMO antibody, is very important in these cases. Next entity which is important for us to know pertaining to optic neuritis is infectious etiology for optic neuritis, where there are various multiple viral and bacterial diseases which can present as optic neuritis. The common infections like syphilis, TB, Lyme, as Dr. Clementine showed, the Bartonella, Herpetic, and HIV too, they can present with optic neuritis. Always look for history of preceding fever, exposure to any infective organism, or travel to endemic areas should be asked frequently, and also exposure to pets. And other features of infective etiology pertaining to CNS, look for any meningitis signs, encephalitis, meningoencephalitis, and ocular features like retinitis, vitritis, posterior vitreous cells, and infective uveitis usually suspect an infective etiology. These patients always require an extensive laboratory workup and CSF analysis to confirm the diagnosis. So an approach for optic neuritis in this era of biomarkers is it's mandatory to include an orbit cut while advising an MRI is very important for all the patients, because they give us a diagnostic clue to clinch the diagnosis and to start the early treatment. Always test for aquaporin and MOG antibodies in patients when you're suspecting an atypical optic neuritis, especially when the patient presents to you with severely impaired vision and there is bilateral or recurrent involvement, poor visual recovery post IV steroids or first-line therapy, and if there is prominent ischemia and perineural optic nerve sheath enhancement in the imaging, or if there is extra optic nerve CNS demyelinating lesion in the imaging. And consider aquaporin for any optic neuritis unless it is a classic MS on MRI or if there is a mild vision loss. And always evaluate for infectious and inflammatory test. Always do the infectious and inflammatory test for patients with atypical features or any systemic abnormalities. And this table I have taken from an article by John Chen et al. From the Survey Ophthalmology. And moving on to the management of optic neuritis, acute treatment is always with IV steroids, especially in acute aquaporin positive and MOG optic neuritis. And recent studies have told that earlier steroid therapy may lead to better outcome, especially for aquaporin positive and MOG positive optic neuritis. And there are several studies which state that early plasma exchange also leads to better outcome for aquaporin positive NMO spectrum disorders. In MOGAD, PLEX or IVIG is considered if vision loss is severe or if there is no recovery after the initial therapy. Looking at the long-term immunotherapy, the recommendation is based on the underlying cause. All cases of aquaporin positive NMO spectrum disorders require sustained immunotherapy, and the choice could be rituximab, azathioprine, or mycophenolate mofetil, and rituximab would be the first choice. And it is important to note that MS disease-modifying drug, they are not only ineffective for aquaporin positive optic neuritis, but they can worsen the disease process. So always remember to rule out aquaporin positivity in if you're suspecting suspecting MS before starting the disease-modifying drugs. In MOG, long-term immunotherapy is typically reserved for relapsing cases, or if they are having significant residual defects after the first attack. And there is a groundbreaking trial which has come up with eculizumab, which is a complement C5 neutralizing IgG for which is a targeted therapy for aquaporin positive NMO spectrum disorder, which has recently received the US FDA approval. And I think in India also it is available, but I'm not sure about the experience of eculizumab here. I don't have experience. I would like to take the panel's experience on this if they have anything during the discussion. So let me conclude with a short case. A 23-year-old male came with the complaints of right eye, followed by the left eye diminution of vision within a span of 3 days, which was painless over the past 1 month. And there was no other positive history. Systemic history was unremarkable. Family history was also nothing relevant. He had received IV steroids followed by oral steroids, and he was on 40 milligram of steroid when he had presented to us. And on examination, vision was 3/16, both the eyes, pupils were sluggish, color vision was poor, and the anterior segment examination was normal otherwise. And this was a disc picture, had some developed some pallor by the time he presented in both the eyes. And this was a visual field, had some peripheral and central defects in the right eye and advanced field loss in the left eye. And this was the MRI cut. The brain was normal, but he had significant optic nerve in thickening and patchy enhancement, retrobulbar, as well as some intracranial portion of the optic nerve was also involved. I'm sorry, I have not included that cut. So he underwent a complete blood workup. ESR was normal. NMO MOG was negative. All the autoimmune granulomatous workup was negative. CSF showed some pleocytosis. Glucose and proteins were normal. He was negative for TB also. So provisional diagnosis was atypical optic neuritis. And because of the long segment involvement, bilateral vision loss with the poor recovery and post-steroid, poor recovery, the steroid, he was suspected seronegative NMO spectrum disorder. But going back to the clinical profile, young adolescent male with a sequential vision loss. Sequential vision loss. The genetic testing was done, which came out positive for 11778 mutation. So it was a case of LHON. So I would suggest early clinical recognition of optic neuritis is important in determining the potential etiology, which helps us in prognostication and deciding on the treatment. So my take-home message is the literature evidence shows that optic neuritis is more atypical in Asian population, and introduction of the serological testing has expanded our understanding and treatment options for optic neuritis, which has enabled us for an earlier and an accurate diagnosis and then decide on further treatment. Although typical optic neuritis doesn't warrant screening for seromarkers, but patients with atypical features, I would recommend screening for NMO and MOG antibodies. Thank you so much. I wish you all a happy Diwali.
Dr. Durga, that was a wonderful presentation. I have one question for you and the panel. How often is it that you have come across an infectious optic neuritis in your clinical practice? I mean, as a percentage of the cases that you would be seeing with typical optic neuritis vis-a-vis an infective. Like, I remember I had one patient who actually turned out to be HIV positive and a progressive multifocal leukoencephalopathy, and the other patient who was positive for VDRL. Suspected syphilitic, and of course one with a suspected Bartonella. This was like spanning a period of 8 to 9 years. I know that it is important to recognize these cases, but just to be sure, like what percentage of patients with optic neuritis, referred as optic neuritis, would you be seeing an infectious etiology?
Sir, I have a limited experience in front of all of you, but once I have shared, Dr. Ambika ma'am, and I have seen one patient with her. Like he was he presented like a neuroretinitis, and then on evaluation he was HIV positive and turned out to be syphilis. I feel association of other ocular association of any vitreous cells or uveitis, we should think of infective etiology. I would like to take others' opinion, expert panel's opinion on this too.
Dr. Gordon or Dr. Clement, would you like to comment on this?
Well, I think locally infective causes of optic neuritis that aren't involving paranasal sinuses or something like this are actually quite unusual. And syphilis is a very good example. But no, I think most of the infective cases we see have infections which start in neighboring structures rather than being entirely within the optic nerve. Of course, it can be involved with meningitis and so on, but a truly isolated optic neuritis, which is infective. I mean, the Bartonella, don't we think these are really post-infective rather than infective? Syphilis, definitely infective. I think I agree. I think I'm not surprised you haven't seen many cases. I would like to say that it's wonderful to see how things have moved on, because it was 10 years ago, more than 10 years ago, we showed in the London population, which is very ethnically diverse, exactly what you're describing now internationally. And at the time there was no information from Asia. We still don't have information from Africa, but we were able to show this that NMO was, and what we now know was MOG. Of course, 20 years ago, we described the chronic relapsing inflammatory optic neuropathy, which is a particular behavior of optic neuritis that needs to be looked out for, that they continue to relapse. And we now know that many of these are MOG. And so it's very interesting to see, whereas the optic neuritis treatment trial in the US, of course, was like 97% white European. And we're getting enough information from, back then we only had information from Singapore, we didn't have information from mainland China, but now there's masses coming from all over Asia. Africa is still a bit of a unknown quantity. What's happening there? I think that's something we should set our sights on. And they in some of our papers, the referees wouldn't allow us to include cases of cryon because they said it wasn't a real disease. The other paper where we showed how the distribution of involvement of the anterior pathway differs in MS and NMO. We also had results in what we now know are MOG, but just to get it published, we had to leave them out because people said crayon wasn't a real disease. And not all crayon is MOG, so it's still there syndromically. But it's wonderful to see all this work coming from around the world now.
Thank you, Dr. Gordon. We now move on to the next presentation by Dr. Verna. She will be talking on an update on Horner syndrome.
Are my slides visible?
Yes, yes.
Yes, so good evening, everyone. At the onset, I would like to thank Dr. Chitra Ramurthy and Dr. Murlidhar for inviting me to speak at this webinar. Well, after listening to all the new and the happening things, let's go back to the basics. The topic I've been given today is the update on Horner syndrome. However, I think this is going to be more of a revision, emphasizing its importance. So as we all know, the ocular sympathetic pathway supplies the sympathetic innervation to the sweat glands on the ipsilateral part of the body and the face, to the dilator muscles of the eye, and the retractor muscles of the upper and the lower lids. Now, the pathway is complex in the sense that it starts at the hypothalamus, goes down through the brainstem, through the cervical cord, comes out through the lower end of the cervical cord, has 3 ganglion, the inferior, middle, and the superior cervical ganglion. Some of the fibers then go along the external carotid artery to supply the sweat glands of the face. while the others go along the carotid plexus up to the cavernous syndrome, goes along the 6th nerve and then along 5-1 to eventually end up in the orbit, where it continues with the long ciliary nerves. So naturally, any interruption of this pathway is going to lead to Horner's syndrome. Now, the classical triad of clinical findings were first described in 1869. Here, the ptosis is usually a mild to moderate ptosis as the Muller's smooth muscle is paralyzed, so this leads to an upper lid ptosis. Similarly, the lower lid is elevated, leading to an upside-down ptosis. This leads to a narrowing of the palpebral fissure and an apparent enophthalmos. So, Horner's is the only neurogenic cause of an upside-down ptosis. Now, since the sympathetic innervation is affected, the iris dilator muscle is paralyzed, so there are no forces to counter the sphincter muscle. So there's a constriction of the pupil or meiosis occurs. There's a loss of pseudomotor control, hence a loss of sweating or anhidrosis. However, this is a little difficult to elicit as the patient may not notice it. Other clinical findings include conjunctival hyperemia, the Harlequin sign, where the pale side of the face is the one with the sympathetic deficit, hypochromic iris, which is seen in congenital Horner's, and the dilatation lag. So let's go a little into anisocoria. So efferent abnormalities, we can classify anisocoria as more in the dark on the light. So if it is more in the dark, we need to differentiate it from a physiological anisocoria. So in the dark, there's a slower dilatation of the sympathetic denervated pupil when compared to the normal pupil. And this can be confirmed by the cocaine test, where norepinephrine is not released in the synapse of the Horner's syndrome, so it fails to dilate the affected eye. The aprochloride test, which is based on the denervation hypersensitivity, so here the alpha-1 activity predominates, so the Horner's pupils dilate. However, practically, we don't use these tests as they are not available in India. Now, a neuro-ophthalmic diagnosis does not end here. We need to determine the site and the etiology for a complete diagnosis. So, Horner's can be acute due to neck trauma or dissection. It could be chronic due to neck masses, thyroid lesions, or malignancies. So, remember that an acute and painful Horner's is considered an ICA dissection unless proved otherwise. This is one of the conditions where the ptosis is considered a deadly ptosis. So the patient may give a history of neck trauma. He may complain of acute pain in the forehead, around the orbit, in the neck, transient monocular vision loss, diplopia. You can get a characteristic crescent moon sign on the MRA. And remember, within the first 2 weeks, there's a high risk of stroke in the distribution of the middle cerebral artery. Next, you need to decipher whether it's an isolated or a non-isolated Horner's. So non-isolated meaning it's associated with other neurological signs. For example, a patient with ataxia and nystagmus, you'll be looking at a brainstem lesion. Patient with pain or weakness in the arm, you'll think of a brachial plexus abnormality. If a patient has diplopia, you'll think of a lesion in the cavernous sinus or in the skull base. Now, as I mentioned, this ocular sympathetic pathway is on the outside of the cervical carotid artery. So it's highly susceptible to compression, to trauma, to dissection, and inflammation. Now, the superior cervical ganglion divides this pathway into preganglionic and postganglionic segments. So the preganglionic segment is the segment proximal to the superior cervical ganglion and is again divided into first order or second order neurons. The postganglionic or the third order neurons is the portion of the pathway between the superior cervical ganglion and the eye. And to localize this lesion, whether it's preganglionic or postganglionic, we have the hydroxyamphetamine hydrobromide 1% test, where pupils do not dilate in postganglionic lesions as the nerve endings are destroyed. So the central or the first order neurons begins at the hypothalamus and extends to the ciliospinal center of Budge-Waller at CAT2. Here, anhidrosis is on the entire half of the body. It is always associated with neurological signs. For example, hypothalamic lesions may have contralateral hemiparesis or hemiesthesia. Wallenberg syndrome, limb ataxia, dysarthria, dysphagia, latropulsion, etc. Alternating Horner's is also due to a cervical spine lesion like syringomyelia. And we need to remember that demyelination, multiple sclerosis, and like this case of neuromyelitis optica can also lead to Horner's. Now, the second order neuron starts from the ciliospinal center of Budge-Waller to the superior cervical ganglion. Here, the anhidrosis is on the ipsilateral side of the head, face, and neck. So, malignancies from the lung or breast are the commonest. We have syndromes like the Villeret, which have associated lower cranial nerves involvement, the Roland-Page syndrome, which has associated paralysis of the phrenic, vagus, and recurrent laryngeal nerves, and other benign lesions, thyroid, goiter, paravertebral masses, Pancoast tumors as shown here. Now coming to the postganglionic lesion, so this pathway extends from the superior cervical ganglion to the orbit. The etiologies can be extracranial or intracranial. Here, dissections of the internal carotid artery, as I mentioned, it's a diagnosis you cannot afford to miss. So it could be inflammatory lesions or masses in the neck, skull base fractures, etc. It could be infectious etiologies like this case of cavernous sinus syndrome due to aspergillosis. It could be tumors, as in this case of nasal pharyngeal carcinomas. So neoplastic etiologies account for about 35 to 60% of the cases. Now, compared to the West, the incidence of whiplash and seatbelt injuries in India would probably be less as we have more two-wheeler accidents. So accidents causing ICA dissections, disc herniations, brachial plexus trauma, etc. can also cause Horner's. Additionally, iatrogenic causes account for 10 to 18%. It could be post-coronary artery bypass surgery, pneumothorax, insertion of the pacemaker, chest tubes, following chiropractic manipulation after thyroidectomy, etc. So there are a number of etiologies that we as neuro-ophthalmologists should pick up. Malignancies, tumors, infarctions, strokes, demyelination, and so on. So this table summarizes the sites and the common etiologies at each site. An imaging algorithm was proposed by Dr. Parmar from the University of Michigan and NANOS 2024, where he recommended in isolated cases, if it was acute, a CTA or an MRA should be ordered, chronic CT or MR neck, which is from the skull base right down to the superior mediastinum. And in non-isolated cases, depending on the site of lesion, the imaging should be advised. So coming to a brief outline of the management, if it's a carotid artery dissection, MRA or CTA neck should be done, refer to a neurologist for immediate treatment with anticoagulation. In children, rule out a history of trauma, and after pediatric consultation, evaluate thoroughly to rule out systemic malignancies. Urine catecholamine metabolite should be checked to rule out neuroblastoma. And in children, especially in children, if the site is not localized, a shotgun approach should be used. That is, MRI head, neck, and chest should be advised. For a brainstem, myelopathic or cavernous sinus lesion, MRI brain and spine with contrast, followed by a neurologist or neurosurgeon referral. And if a thoracic malignancy is suspected, MRI with contrast to look for pulmonary apex or paravertebral lesions. So from my talk, I have 3 take-home points. As with all neuro-ophthalmic cases, a proper history should be taken. Many a times you have to do a little probing. For example, a patient with a lung or a breast malignancy or an injury to the chest may not think it's relevant to mention this to an eye doctor. My second point is that a good clinical examination is a must. By that, I don't mean just an ophthalmic examination. You have to observe the patient as he enters your cubicle. Does he have an ataxia or weakness of limbs? Look for associated neurological signs. And if you follow step 1 and 2 properly, you should have a rough idea of the site and the etiology. So in order to steer the radiologist in the correct direction, step 3, that is the correct imaging should be advised. The MRI, A with or without contrast, brain, neck, thorax, spine.
Doctor, 1 minute more.
And then appropriate referrals should be made. Thank you.
That was a wonderful talk, Dr. Vinna. So crisp and clear and so well within time. Truly thankful. Like each talk has excelled the other. Very nice. Mulli, would you like to take a question before we go on to Rashmin's talk?
Yeah, so I have a question. I mean, Dr. Clement or Dr. Plant could answer this also. Do you have access to this cocaine? And we in India don't have access to this cocaine and hydroxyamphetamine drops for testing Horner syndrome. So do you have access and do you routinely use it in your clinical practice, or is your diagnosis largely clinical?
Well, we don't have I used to have a stock of cocaine and apraclonidine, but not apraclonidine. I used to have a stock of cocaine and hydroxyamphetamine, but it's since been confiscated by the authorities. So I don't have that anymore. If we wanted cocaine, we sometimes have to just see if we can get some from the ENT people who occasionally still have a little bit left for their anesthesia in the nasal cavity. We've relied a lot on apraclonidine for the pharmacological testing, and the rest is clinical because we really can't get any of the others anymore. Over.
How soon would
Yes.
the apraclonidine test be? We had it available sometime back in India. Now we don't have it. But how soon would it be positive? Because it depends on denervation hypersensitivity of the sympathetic fibers. So how soon after onset would it?
Well, I do recall there's 1 or 2 papers that suggested it could be positive as early as within a week. So you don't really you might not have to wait that long. But you're right. Typically, I guess we wait for denervation hypersensitivity. I don't know if Dr. Plant has any further comment on this.
No, I agree. It can be positive surprisingly early. Certainly worth trying. There aren't all that many situations where you can't make the diagnosis of Horner's from the rest of the examination, though.
Thank you.
It's worth mentioning depigmentation of the iris in very long-standing cases. They're not necessarily congenital.
Yes. Yes.
Because the
you.
melanocytes are also influenced by the sympathetic input.
Yes, thank you for your input, Doctor. Shall we go on to our last speaker, Dr. Rashmin's video recording, Murli?
Yeah, yes, madam. Dr. Rashmin is not here. So we'll be sharing his recorded presentation. Wilmurugan, can you share the presentation?
I would like to thank the Eye Foundation, Dr. Chitra, Dr. Murli, for inviting me for this webinar. I'm sorry I'm not able to join you live. Murli wanted me to talk about myasthenia and what are the risks, I believe, of missing out. So let me start with the story of this patient. So this was a 30-year-old male who presented to us with the complaints of acquired ptosis. He was not a good historian, though he did mention that maybe he had a slight trauma on the right side of the forehead, and after that there was this drooping. And again, he was not really entirely clear about the diurnal variation. In other words, the history was not really helpful in this patient. He was also very keen for cosmetic reason to get his ptosis corrected. So the ptosis surgery was done since there were the clinical features were equivocal. And this is what happened around 6 months from surgery. And his entire ocular feature, he actually attributed to the surgery. So he came, you can see the scar, the right operation was done, but then he started having this very vague ocular motility issues. You can see here, he has a squint, he has this ocular motility where the eyes are moving in a disparate fashion, and he thought that it was all entirely related to his ptosis surgery. So that's one of the pitfalls of missing out on myasthenia, and that's the whole core issue of my talk. One more patient, this 32-year-old gentleman, again presented with the ptosis, and the top two pictures are the pre-op pictures. where he had this ptosis of the right eye, which he wanted to get corrected. He was in fact told that it doesn't really sound like an apparent ptosis, so maybe we should wait out. However, again, he was in a hurry and he underwent surgery somewhere, and the bottom two photographs are post-op photographs, and you see here there is a scar of a ptosis correction that he underwent. Not only that the ptosis has worsened in the post-op period, but now he has an additional lid bag. So one more reason to make sure that we don't really miss out on ocular myasthenia gravis. One more patient on the left side, patient, a 70-year-old female, bilateral ptosis. She was saying that maybe her ptosis gets a little worse in the evening. So the question really is that what are the ways by which we can avoid those two disasters that I highlighted in two patients? And can we confirm the diagnosis of ocular myasthenia? So one of the ways by which you can do, and this is another patient, again, a similar age group, she was told that she has an apparent ptosis and that can be corrected. However, as you see here now, when the ocular motility is being checked, we'll find that there is that little bit of lid hopping. And with this motility check, you'll find that the ptosis has already worsened. In other words, clinical examination would reveal that there is a fatigability, even if the patient is not very clear about the presence of worsening of problems in the evening. One more sign which will help you, same patient. You find here that little bit of lid hopping when the ocular motility is being checked. We can test for Cogan's lid twitch. Here, you ask the patient to look down for around 30 seconds, and then they can make up saccades to the primary position, and you find here that there is that little bit of twitch before the lid settles down. So that is Cogan's lid twitch. So presence of fatigability, presence of Cogan's lid twitch, enhancement of ptosis, weakness of orbicularis oculi muscle. These are some of the features which will help us clinically to suspect or to increase the suspicion of presence of ocular myasthenia gravis. So that's Cogan's lid twitch. ICE test, again, has a very high specificity and sensitivity to diagnose patient with ocular myasthenia gravis. As you can see here, a left mild ptosis and both eyes being perfectly normal after ICE test. Though highly specific and with high sensitivity, one need to remember that it is not really reliable in complete ptosis, and it does not work as well when the patient has mainly ocular motility issues and not really ptosis. What about other tests? Can we confirm, apart from these clinical tests and ICE test, can we confirm the presence of ocular myasthenia gravis in a patient who has presented to us? There are three options. You can do serological tests, electrophysiological tests, and pharmacological tests. Let's see what is the current thinking about all three. So the question, of course, is that can really serology help to confirm the diagnosis of ocular myasthenia gravis? Now, let's say if we have a clinical suspicion of the patient having ocular myasthenia gravis, and then we do this acetylcholine receptor antibodies. And what if they come back negative? Well, it does not really rule out ocular myasthenia gravis because it has been demonstrated in 80 to 90% of the patients who have generalized myasthenia. However, the presence of antibodies in patients with pure ocular myasthenia gravis initially was reported to be only 30 to 40%. So in less than 50% of the patients in ocular myasthenia gravis, you may find this antibody. So in other words, presence of antibodies would help, but the absence of acetylcholine receptor antibodies does not really rule out ocular myasthenia gravis. However, there have been now the recent studies where the presence of acetylcholine receptor antibodies in pure ocular myasthenia gravis has increased to around 70 to 80% in a couple of studies. And this has been attributed more to the improvement in improvement in the way we conduct these assays, the cell-based assays, And that's the reason why maybe we are picking up the antibodies better. Also, there is also thought there is a little change in the presentation. So if ocular myasthenia gravis presents in a later stage, you're much more likely to pick up these antibodies. What about those? So those were acetylcholine receptor antibodies. What about other antibodies like anti-MuSK myasthenia gravis? It was believed that anti-MuSK myasthenia gravis is much more useful in generalized myasthenia because it presents in one of these three ways, either a very severe ocular bulbar syndrome or presence with weakness of neck, shoulder, and respiratory muscles with late onset ocular involvement, or a typical generalized myasthenia gravis. However, recent study has shown that up to 55 to 58% of the patient's ocular myasthenia gravis can have presence of anti-MuSK myasthenia gravis. So it's reasonable actually to request for anti-MuSK myasthenia gravis, anti-MuSK antibodies in patients who have suspicion of ocular myasthenia gravis. One need to also understand that the treatment parameter changes when patient has presence of these antibodies. Double seronegative myasthenia gravis, where both acetylcholine receptor antibodies are absent and anti-MuSK antibodies are absent. There are a few antibodies which are being tested for, like low-density lipoprotein receptor-related LRP4 antibodies or antibodies to contractin have been detected in about 20% of the patients with DSMG. The reason why these are important to know is because each one of these, so positive LRP4, the patient profile or the presentation of the myasthenia and the treatment may change a little bit. Some of these may not be available anywhere at this moment. So that's about serology. What about electrophysiology? Can electrophysiology help us to conclude the diagnosis of ocular myasthenia gravis? So repeated nerve fiber layer stimulation studies like RNS, and single fiber EMG, SF-EMG. These are the two studies that can be done. RNS is much more useful in generalized myasthenia. Decremental response in pure ocular form of myasthenia gravis is present only in 1/3 of the patients. However, single fiber EMG sensitivity increases in patients who have ocular myasthenia gravis up to 85%. The single fiber EMG also has a very high, up to 90% of a positive predictive value. So if patient has a decremental response, when we do single fiber EMG on orbicularis oculi patients, the diagnosis of ocular myasthenia gravis is present. However, the negative predictive value of SF-EMG is around 62%, and that's the reason why negative SF-EMG in isolation does not really rule out ocular myasthenia gravis. However, there has been some studies which have said that ICE test and SF-EMG together increases the sensitivity. So if ICE test also is negative and SF-EMG also is equivocal, then you may have to revisit the diagnosis of ocular myasthenia gravis. You may be dealing with something else. So both together increases the sensitivity of the diagnosis. So electrophysiology has a role to play, and especially single fiber EMG on orbicularis oculi muscle. However, one has to understand that SF-EMG is a specialized test and sometimes may not be available because of lack of expertise. What about pharmacological tests? Tensilon test, the endrophonium chloride test, it's a rapid test, intravenous test, works very well with a patient who has ptosis, while prostigmine test, patient has to wait for around half an hour. It's given intramuscular, and it works very well in patients who have mainly diplopia as their chief presenting problem. These tests should be done only under supervision and preferably with ICU backup. So these are two questions. When a patient comes to you, is it myasthenia because you don't know, miss out myasthenia? And second, how do I confirm it? And third important question is that once you confirm that yes, this patient has ocular myasthenia, it's basically an ocular presentation of a generalized disease. So the question is, can it generalize? Can it go to other muscles? And these are the factors which will tell you that yes, these are the high risk for generalizations. Like if patient already has acetylcholine receptor antibodies and higher titers in a pure form of myasthenia, he is more likely to generalize. Presence of thymoma or thymic hyperplasia, older patients are more likely to generalize. Abnormal RNS and severity of symptoms, these are the risk factors for generalization, which has to be kept in mind. And to conclude, of course, some of the other contributory factors for ocular myasthenia gravis, like patient already had a propensity to develop ocular myasthenia, then if he ends up taking quinidine, propranolol, or lithium, then there can be unmasking of ocular myasthenia gravis or aggravation of already present OMG. Further impairment of neuromuscular conduction can occur if the patient takes aminoglycosides, and the drug induced, like penicillamine and statin, can produce myasthenia gravis. There have been reports of COVID and COVID vaccines producing a lot of autoimmune disorders, including myasthenia gravis. However, in case of ocular myasthenia gravis, it is much more related to the disease itself rather than the vaccine. There are not many cases of ocular myasthenia gravis presenting with vaccines to COVID. So to conclude, myasthenia gravis, you don't want to miss out myasthenia gravis, and as we highlighted by 2 cases, that if you miss out, there can be a disastrous consequences for the patient, and also there would be implications for your practice. Unfortunately, there is no single test or a group of battery of tests which would surely confirm the presence or absence of ocular myasthenia gravis. However, so it by and large remains a clinical diagnosis with adequate support from various serological tests, electrophysiological tests, and pharmacological tests. One has to remember that some of these pharmacological agents may not be widely available, and it has to be done, as I said, under supervision in settings where ICU support is available. For the brevity of time, I have not included the treatment in this talk. I would like to thank the Eye Foundation once again for inviting me for this talk. Thank you so much.
That was again another wonderful talk. And I think it's been a wonderful evening, though it's ended up quite late. That we've had series of great talks, and I think this is going to be a big storehouse of knowledge for anybody to revisit these talks and hear them. Thank you so much, dear speakers. I don't know how to express our thanks for being there with us and taking part and actively adding great inputs for us. Thanks a lot. Murli?
Thank you. Thank you. I do have a question for Dr. Plant and Dr. Clement. So sometimes when you do a imaging of the mediastinum in patients with myasthenia, the radiologist mentions something vague as thymic hyperplasia or a mild thymic hyperplasia. So what do you do? I mean, would you recommend thymectomy in patients with pure ocular myasthenia gravis? I mean, what is your approach?
Well, unfortunately, Newsom Davis always excluded purely ocular myasthenia from his trials, and so the trial that was done of thymectomy was only on generalized myasthenia, and so you, of course, if your ocular patient becomes generalized, then you have the information. It's the ones who remain purely ocular for long periods of time where you don't know. The other problem is that unless things have changed recently, the radiologists can't distinguish thymoma from thymic hyperplasia when it's just a moderate enlargement. So the view I took was if there was thymic enlargement, and if the patient's symptoms merited it, even if it was purely ocular myasthenia, then I referred the patients for thymectomy. And of course, the operation has got less traumatic. It can be done transthoracically now without splitting the sternum, which it was not a pleasant operation. A lot of our African origin patients developed keloid, and there were problems there. So, but I think that if you're not sure, it can be. We've seen some very, very small thymomas I mean, really, really small, associated with myasthenia. So I think if the clinical situation merits it, then refer for thymectomy. Otherwise, you can monitor radiologically, of course. I'm not advocating thymectomy for every patient you see with ocular myasthenia. Generalized myasthenia, I would say yes.
Yeah, I'm inclined to agree with that. I normally take the advice of the thoracic surgeons because as Dr. Plant has rightly pointed out, nowadays they can do it endoscopically and it's quite recovery from surgery is pretty fast. I think the concern usually is whether it's going to be a thymoma, which then has other implications for malignancy and such. So
Thank you.
we normally have a discussion with the thoracic surgeons, and if there is some concern that there might be a malignancy, then I think they'll go ahead anyway, no matter what the size of the lesion is. So we have that as a discussion. But if it's just purely removing it for the sake of the control of ocular myasthenia, then I agree with Dr. Plant. There are other ways to control the myasthenia besides the thymectomy.
Yes, I think you can hold off, but monitor in some cases. It was a fabulous presentation. The only thing I would comment on is I'm very keen when anyone is involved is examining levator function that you must disable the frontalis muscle. It's very easy to do. You just put your finger here, because otherwise in the videos you're showing, it's partly the levator muscle and partly frontalis that's moving the lid about. But well, we've had a wonderful afternoon of presentations.
Thank you so much. Thanks everyone.
Thank you very much, Murli and Dr. Chitra. Thank you very much for having us.
Thank you so much. Thank you.
Thank you, ma'am. Thank you.
Yeah, bye. Thank you.
Goodbye to you all. Bye-bye.
Good night.
Bye. Good night.
Bye.
It's tea time here.